आप लोग का हो गया?
हाँ नहीं, अभी हम उतना तैयारी नहीं कर पा रहे। अभी हम प्रिंसिपल सुपरिटेंडेंट दोनों का पोस्ट होल्ड कर रहे हैं अपने मेडिकल कॉलेज में।
हाँ,
अभी प्रियंकुर का रिक्वेस्ट था और मोनिका का, तो आई थॉट आई शुड मेक इट।
आप रहोगे तो वहां रहेंगे, आपका तो नाम देखे हैं हम।
Thank you so much, ma'am, for joining.
तो हो गया।
Abadi, Abadi Pranam.
हाँ, खुश रहो विनीता।
Good evening, Priyankur, and good evening to everyone. Nivedita is there. I think Monica is there.
Good evening,
Good
ma'am.
evening, मैडम। विनीता मैम प्रणाम।
Pranam,
साधना है।
Sadhana.
प्रणाम
बहुत अच्छा
आभा दी।
लग रहा है।
हाँ, खुश रहो सुप्रिया।
प्रणाम विनीता दी।
खुश रहो सुप्रिया, खुश रहो साधना।
सब लोग को हाय, गुड इवनिंग।
Good evening, Supriya ma'am.
हाय
गुड
हाय
इवनिंग, गुड इवनिंग।
Monica ma'am, we are live now.
Yes,
Yes,
okay. So we'll have to
Thank you, Abhishek. Yeah. I welcome all the esteemed faculty members and the delegates to the Public Awareness Committee Fogsi meeting, which is the episode 20 with the East Zone Societies. I'm very happy to host this episode because this would be the last episode of this academic year. And Pai sir will be joining in some time because it will be the last webinar for his tenure before the AICOG. This is respect to East Zone Societies, and we are very happy to have Abha ma'am as the guest of honor. I request all the esteemed faculty members to join in for the
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्योर्मामृतं गमय। ॐ शान्ति शान्ति शान्ति।
Thank you. This webinar series is a brainchild of our chairperson, Dr. Priyankur Roy. He is currently holding the post of Public Awareness Committee as a chairperson, and he is also the president of ATA. I welcome Dr. Priyankur to please welcome our faculty members as well as the delegates for this webinar.
Thank you, Monica. Good evening to everyone. As always, it gives me immense pleasure to welcome all of you to this episode, the last episode for this academic year. I especially like to thank Rishikesh Paisa, the President Fogsi, for giving us this opportunity, Madhuri ma'am, Secretary General, and Dr. Alka Pandey ma'am, the Vice President in charge for the Public Awareness Committee, for giving us this opportunity. My heartfelt thanks goes to Monica as well as Shatabdi, who are the coordinators running behind, inviting all the faculties and getting this programs done. So thank you so much to the two of you. And also I would like to thank our East Zone coordinators, that is Dr. Rekha Jha ma'am and Dr. Indranil, for being with us for all the East Zone programs that we conduct. Today we have a special, of course, a guest of honor. In spite of our busy schedule, ma'am has joined us today. We have Dr. Abha Rani Sinha ma'am with us, who is OBGYN per excellence, but currently also holding the responsibility of the administrative responsibility of the medical college that she is in. So I welcome ma'am for joining us, and thank you immensely for being with us today, ma'am.
Thank you.
I'd like to welcome our speakers today, Dr. Sita Ramurthy Pal ma'am, who will be talking on the expanding horizons of first trimester clinic, and Dr. Arita Singh ma'am, who will be talking on menopause and HRT. I hold a special bond with Anita Singh ma'am because it was under her leadership that we had done the virtual East Zone Eva Fogsi in 2020, and the support she had given us was immense. I would also welcome the chairpersons of this session, Dr. Rekha Jha ma'am, Dr. Bandana Das ma'am, Dr. Supriya Jaiswal ma'am, and Dr. Helen for being with us today. Dr. Helen, thank you so much for joining us in spite of the East Zone Eva Fogsi that are going to conduct, and all the best for the East Zone Eva Fogsi. We have a brilliant panel today to be, of course, moderated by none other than Dr. Vinita Singh ma'am, a very vibrant moderator, I would say, and Dr. Nivedita Datta ma'am, who in herself is personified, and I'm sure they'll do a great job. Our expert today is Dr. Sashmita Swain ma'am. Thank you, ma'am, for always supporting us. And our panelists today, we have Dr. Kavita Banwal ma'am, Dr. Devanjana ma'am, Dr. Ranita Roy Chaudhary ma'am, Dr. Shubhabrata, Dr. Ekta, Dr. Sadhna Kumari ma'am, Dr. Santana Sharan ma'am, and Dr. Sudha Jha ma'am. So welcome all of you to this excellent session. I'm sure this is going to be a very enlightening session for all the viewers present over here. And I would especially like to thank all the viewers who have joined us today. And also I would like to thank our partners, academic partners, Corona, who have supported us throughout this year. And I'm sure they'll support us throughout the next couple of years as well. So now I hand over the session to Monica to kindly take us over through the academic session, and also we'll take the blessings from Abha Rani Sinha ma'am before we go on to the academic session.
Priyankur, I request you to please introduce Abha ma'am also.
Yeah, thank you so much.
Can you please call first?
Yeah, so Abha ma'am, of course, they will put on the CV for everyone, but then Abha ma'am, of course, as I said, holds a very special place for all of us, especially once we're present in the East Zone. She is from Patna, but currently the principal of SKMC in Muzaffarpur, professor at the OBGYN department at Muzaffarpur, and she's the treasurer of ISOPAP currently. She's a brilliant academician, and I'm sure some of your teachers are viewers today, some of them are faculties today, and we always love listening to you, and your energy when you're around spreads around, and it brings a lot of excitement in people who are around you, ma'am. So it gives me a lot of pleasure in welcoming you to this forum and request you for a few words of blessings before you get busy and before you leave. I would also invite if you could stay on for the program, put in some of your inputs if possible, but I think that will be difficult. But if you can do that, that would be great on our part as well, ma'am. So I welcome you to this forum and request you for a few words of blessings to everyone.
Thank you so much, Dr. Priyankur, for inviting me as guest of honor. I'm really honored and overwhelmed. And you have done a phenomenal job in your tenure as Chairperson, Public Awareness Committee. And under the leadership of our very dynamic President, Dr. Rishikesh Pai, whose leadership has been exemplary, and under the leadership of Dr. Madhuri Patel and Dr. Alka Pandey. And I'm really impressed by the conveners of this program, the coordinators of this program, Dr. Monica, who has been communicating with us every day. And the other one is Dr. Shatabdi, I think so. And the conveners, Dr. Rekha Jha and Dr. Indranil Datta. The scientific program has been very well crafted. Yeah, the topics are very well chosen. And you have got brilliant speakers to deliberate on these subjects, Dr. Sitaram Murthy Pal and Dr. Anita Singh. And the chairpersons are also going to give their very valuable inputs. Dr. Rekha Jha, Dr. Supriya Jaiswal, Dr. Vandana Das, and of course, Dr. Helen, who is busy with the year Fogsi preparations. And the panel discussion, again, the topic is very important. That is management of AUB in perimenopausal age group. And we have brilliant moderators for that, Dr. Vinita Singh and Dr. Nivedita Datta. And as expert, Dr. Sasmita Swen. And as panelists, I have all my friends from East Zone, Dr. Kavita Barnwal, Dr. Sudha Jha, Dr. Devjana Datta Majumdar, Dr. Shantana Saran, Dr. Anita Roy Chaudhary, Dr. Sadhna Kumari, Dr. Subhabrata Sarkar, and Dr. Ekta Verma. So I know you're going to have a very good program today. And I'll try to stay for some time if I don't get any emergency call. And it's indeed been an honor to be present here. Thank you so much once again for inviting me. Thank you.
Thank you, ma'am. We'll always look forward to your blessings as a teacher, as a person per se, and of course, ma'am, we wish you all the best for your future positions and posts in Fogsi as well. So thank you so much, ma'am.
Thank you so much, Priyanka.
Over to you, Monica. Can you take us through?
Thank you, Abha ma'am, for joining us and gracing the inauguration of this webinar. We now move forward with the academic session. The first session is on the antenatal care, as November was the Antenatal Awareness Month. For this, we have none other than Dr. Sita Pal ma'am, who will be joining us for this talk. The chairpersons for this session are Dr. Rekha Jha madam and Dr. Vandana Das ma'am. Can we have the CVs, please? Dr. Rekha Jha madam is also the East Zone Coordinator for Public Awareness Committee. She is the past President of the Bhagalpur OBGY Society, the past Secretary of IMA Bhagalpur, the past Vice President of IMA Bhagalpur. She has been actively involved in all the Public Awareness Committee activities throughout the year with the East Zone. We welcome you, ma'am. And our next chairperson for today's session is Dr. Vandana Das madam. She is a senior consultant at Silchar and is attached with the family planning wing of Silchar Medical College. She has been trained in endoscopy and ultrasound from the Royal Free Hospital, UK. She has been the past secretary and past president of the Silchar OBGY Society. We welcome you, ma'am. I request Vandana madam to please introduce Sita ma'am first.
Good evening. Dr. Priyanku Rai, Chairperson Public Awareness Committee, Dr. Abha Rani Singh, guest of honor of today's webinar, and all esteemed members present in the webinar, I welcome you and a warm greetings to all of you. I am honored and privileged, for which first I'd like to convey my sincere thanks to the organizer, especially Dr. Monica, for giving me the opportunity to chair a session of a prestigious public awareness committee. The topic of this session 1 is extending horizon of first trimester clinic. The speaker is none other than Dr. Sita Ramurthy Paul. She is DGO, MD, FICOG, FRCOG, RCOG Diploma in Advanced Obstetric Ultrasonography. At present, working as consultant of fetal medicine and obstetric in Apollo Multi-Speciality Hospital, Kolkata. She is clinical secretary of Bengal OBGY Society, also chairperson elect in Genetic and Fetal Medicine Committee Fogsi 23-25 session. I would also like to add that she is also Honorable Vice President of Society of Fetal Medicine Kolkata, Clinical Secretary of ISOPAR Kolkata Chapter, and Examiner and Faculty of MRCOG Part 3. Such a bright career, Dr. Sita Ramurthy Paul. Please start your presentation.
Thank you, ma'am, for joining us in spite of your busy traveling schedule.
Thank you.
Yeah. Ma'am, would you like to say a few words before we start the record?
As I was traveling, when Monica asked me, I couldn't refuse her. So we decided to record the talk. I'm still on the road, so if we had network issues, so I have recorded the talk and sent. I won't waste any time. But thank you once again, Monica and Priyanku, and all the Fogsi leadership. Thank you so much, and greetings to Avarani, Madam, and Anita, ma'am. Yeah,
sure, ma'am. Have a safe journey, ma'am. We will start with the recording.
Good evening,
Abhishek,
everyone.
please start the recording.
At the outset, I pay my greetings to the President Fogsi, Dr. Rishikesh Pai, Dr. Madhuri Patel, and I express my gratitude.
I'd just like to add that I'm currently the chairperson of the Genetics and Fetal
Kalyan
Committee.
And mostly to, and most importantly to Monica, who has been very enthusiastically coordinating all this. So thank you for this opportunity, and thank you, chairpersons. So my topic for today is expanding horizons of first trimester clinic, and how we have progressed from what we used to do before, and what else we can, and there's so much we can do in this first trimester. That's me for you, and thank you once again. So initially in 2016, the antenatal clinic was a typical model where you would have the first contact up to 12 weeks, and then subsequently 2 contacts, and then most of the visits were in the third trimester. But over the years, especially with the new model, which Professor Kypris Nicolaides got about it, saying that there was this inverted pyramid of care, where instead of having most of the visits in the third trimester,
any problem, Monica?
In the first trimester, within the first 12 weeks or up to 14 weeks, and then depending on where they stand, we can either triage them into a low risk category, and to them call them directly at 20 weeks. Or then they have specialist care, and then we can take it forward from there, so that they need specialized and more careful monitoring in these patients. So why first trimester? Because the first trimester is it gives a window of opportunity to all that we can do in that. It's a crucial window for optimizing the care of the women. You can screen for a lot of maternal problems, and this first trimester, especially between the 11th to 14th week, is an important landmark for the fetal evaluation, because a lot
Hello,
of
what
things can be
happened,
assessed,
Monica?
a lot of things can be evaluated. Most of the
Everyone's
development of fetus is already, the formation or the organogenesis is already occurred. So we can sort of evaluate the structures and more importantly, predict in terms of looking, if you combine it with other things, as we will see in subsequent slides, we then predict whether this risk or whether this mother is at risk of developing future conditions. So this first trimester forms the base of the pyramid of the modern antenatal care. Now, if you go to see what are the conditions that warrant screening, it's basically in the mother, we can, in the first trimester, you can screen for anemia, Rh isoimmunization, hyperglycemia in
Not the
pregnancy,
beginning, Monica.
hypertensive disorders of pregnancy, which is important. We'll see infections that we routinely screen, thyroid disorders, which has to be universally screened. And most importantly, carrier screening is very, very important so that we can screen these women, the families, the partner and the family, so that if anything needs to be done, all can be done in the first trimester itself. Carrier screening in the first visit is basically, as I said, you do a complete blood count and you look for hemoglobin, and if it is if the MCV is less than 80 and MCH is less than 27, we must think in terms of whether this woman could be a thalassemia trait. And the easiest ways to do is to also look at the Menzel's index, where we look at the MCV upon RBC count, and anything less than 13 would indicate that this lady could be a thalassemia minor patient. This would be a sort of a crude estimate, and then this has to be confirmed or by performing by doing the HPLC, high performance liquid chromatography, and then you actually quantify the HbA2 and F levels by looking at the graphs, so that you can make out whether she's an HB beta thalassemia carrier or E carrier. And depending on whether there's a carrier, you have to screen the husband, because if both the parents are carriers, which is a autosomal recessive condition, there is a 25% chance that the fetus might get affected. And then it is important to do that prenatally, ideally, so that if we can identify the mutation in these couples before the lady falls pregnant, then that would be ideal. But even if that's not the case, most of the women come when they've already, with the previous history of a child being affected, and then we see them in their next pregnancy, where we can still do a chorionic villus sampling and identify these fetuses who are at risk. And once that has been identified, you must extend the screening to the relatives who may be at risk, so that you inform the family that this could be the problem in their family. So this is just a sort of flow chart where you do a complete blood count and you find that the hemoglobin is low and there is low MCH, low MCV, and then decide whether there are other causes of anemia. And if serum ferritin is less than 12, you consider iron, but if it's more than 12, we decide upon the electrophoresis, HPLC, and typically you will have HbA2, which is about 4%. But that would be a beta thalassemia trait. But if it's more, around 10%, then that would be HBE, and we can accordingly classify them. And then depending on whether to find the mutation, you can do further analysis. What about in the fetus? We can screen the fetuses for aneuploidy, for structural defects in the fetus. We can screen whether this fetus is at risk of developing growth restriction, and whether this lady is going to have a preterm birth. And amongst all this, ultrasound is the cornerstone, because it provides us most of the information where we can screen and stratify them. So the first trimester ultrasound, which is usually done by transvaginal scan, is mainly done to confirm the presence of an intrauterine pregnancy. You estimate the gestational age. Very importantly, you diagnose multiple pregnancy and you determine the chorionicity. And of course, you can suspect, if it's suspected ectopic pregnancy, we can evaluate. But ISUVOG, which is our Bible, that is the International Society of Ultrasound and Obs and Gynae, they have said that there is no reason to offer routine early ultrasound just to confirm an ongoing early pregnancy in the absence of any clinical concerns, which means that there are any other clinical symptoms or indications or suspicion of ectopic, then we can do an early ultrasound. What is most important is this late first trimester ultrasound, which comes between 11 to 13 weeks, where we can do a lot of things, that is screen for aneuploidies, assess structural defects, screen for neural tube defects, screen for preeclampsia, growth restriction, and preterm birth. And then we add all these other markers that increases your sensitivity. So in terms of aneuploidy screening, we have come a long way from 1970, where we used to do karyotype only based on maternal age. And then we went on to have the rapid aneuploidy testing and the combined testing. And now we are in the era of molecular NIPT, which has taken the stage of aneuploidy by storm. So in aneuploidy, we have different models where initially age was done, but it is no longer recommended. And now the most recommended test is combining the age with the maternal factors and doing the first trimester scan, where we take the CRL, measure the NT depending on the CRL, and add the biochemical markers, which is quite sensitive, and for a false positive rate of 5%. And then you can add different things, like there is a T1 quad where you add PLGF, and a first trimester penta screen where you add diaminic inhibin, and they all have a high detection rate and a low false positive rate. So when you look at these screening tests, the most commonly used screening test is the combined test, which has a 93 to 96%, 85 to 95% sensitivity for a 5% false positive rate. But if we add the other markers, then then the sensitivity increases, the detection rate increases to almost 96%. And of course, if we miss the boat in the first trimester, we have the quadruple test. We no longer use the triple test, because any test which has a sensitivity of less than 70% should not be used. So that is why if we have the first trimester, we do the double test, and if in the second trimester, we do only the quadruple test, which has a sensitivity of around 75%. Now, as I said, these are the different screening methods and their efficiency. And if you add the cell-free DNA, that increases the sensitivity to 99%. And why cell-free DNA does that? Because this is basically a placental trophoblastic origin, which freely circulates in the maternal blood, and the difference is the size allows it to be distinguished from maternal fragments, and it is seen from 10 weeks onwards, and it disappears after birth. So basically, if you see the sensitivity, it performs very, very well for trisomy 21 up to the rate of 99.7%, and even for other trisomies equally well. And this was meta-analysis showed that it is almost as for a false positive rate of 0.04%. Now, in multiple pregnancy, you must remember that the biochemical screen that we do is a pseudo risk. So whatever we do, combined screening is still effective. So, but biochemical markers should not be done. And the risk depends upon the chorionicity. So if it's a monochorionic, they both share the same genetic material. So it's a single probability for the whole pregnancy. But if it's a dichorionic, then it is fetus specific. And when you when you use NIPT for twins, it actually performs much better than singleton. So if you have missed this combined test for multiple pregnancy and she's come in the second trimester, I think the best test would be to do a NIPS rather than not doing anything at all. When you look at screening for aneuploidy, it is very essential. It is quite the same thing that we do in the second trimester can be applied in the first trimester, and that allows for earlier detection of lethal cases so that we can give an option to the couple of terminating the fetuses. And if there are any suspicious cases at this point, we can recall them earlier rather than waiting till 20 weeks, so that something can be done by the 20 weeks and we can take a call. So there is adequate time to evaluate, investigate, and decide the further course of action. So there is a list, the guidelines which ISRO has provided for screening for anomalies in the first trimester. So typically, when we look, we can see the entire, this is the head, the chest with the heart, the stomach in the left position, and then the cord insertion and the two limbs. So in one sweep, you can see the entire anatomy, and then you measure the CRL, you look at this, you can see the heart, and evaluation of the heart, and you can see the outflow tracts, and in one sweep you can sort of make sure that this baby is normal. So So screening for structural defects in the first trimester, the studies have said that when there are anomalies which are lethal, like eucrania and cephalocele, there is 100% detection rate. And even for anomalies like cystic hygroma, holoprosencephaly, megacystis, the detection rate is anywhere between 50 to 99%. Of course, we must remember that there are certain anomalies may not get detected in the first trimester, so that has to be counseled, like brain anomalies or GI tract anomalies. And so these are the ones which are always detectable, that are potentially detectable and undetectable. So it has its limitations, but most of the lethal anomalies can be picked up in the first trimester. Like this lady had a pleural effusion, bilateral pleural effusion. This patient, you can see a big encephalocele. This is with a diaphragmatic hernia, and this is a megacystic. So these are most of the times lethal anomalies, or we can give the option of doing an invasive and deciding on whether termination has to be done. In terms of preeclampsia, screening for preeclampsia, we know that there is a placental dysfunction which causes ischemia. So that decreases uterine blood flow, uterine artery flow, decreases PAPE and PLGF, and which causes vascular compromise and increases the S-split. And all these cause endothelial and vascular dysfunction, resulting in hypertension, proteinuria, and liver dysfunction. So what are the strategies that we used in preeclampsia screening? Basically, clinical history, maternal characteristics. But if you combine all this in the first trimester with the mean arterial pressure, uterine artery Dopplers, and the biomarkers, the sensitivity increases. So this is again the preeclampsia screening timeline, which has gone through many phases. And we can do a gestosis score as well in the first trimester, where we just based on the history, we assess a score. And this is very good for low resource settings, where you put up these scores. And the most important thing, that this is a dynamic scoring system. So every time the patient comes to your clinic, you rescore them and decide what needs to be done further. Now, when you do the first trimester ultrasound, you also do a first trimester uterine artery PI. And any woman who has a uterine artery PI above the 90th centile, there is a 48% of chances that they will develop early PE, and 26% of women who will develop any PV for a 10% screen positive rate. So when all this was put up in the competing risk models for early screening, they came up that if you use these first trimester markers, you can detect early PE up to the range of 100%. That is PAPE, uterine artery PI, mean arterial pressure, and PLGF. So, and this is a fetal first trimester prediction model by use a triple test, that is the mean arterial pressure, uterine artery PI, and PLGF, that gives a very good sensitivity of 90% for a 10% false positive rate. So this is typically, you use a maternal characteristics due to uterine artery PI, use the mean arterial pressure in the correct way, and collect the blood for PLGF, and that gives you the assessment. So in accordance with that, the FIGO guidelines have come up that in the first trimester, if you use this, it is most predictive of early PE. The app is freely available. You can download it, and and when it is not possible to measure biochemical markers, you can just do a baseline screening test with maternal factors and mean arterial pressure. And even in low resource settings, if you don't have, you can triage, you can do a 2-stage screening, where the first stage is to just screen them by maternal history. And if they are screen positive, then you can do other methods by PLGF and uterine artery PI. So typically a report comes back like this, whether when you use PLGF, that the risk comes back as high risk for PE. Now, what about growth restriction? Again, studies have said that if you include the first trimester blood pressure, uterine artery PI, PLGF, and S-split1, and that could predict early onset FGR for 86% and 66% for late onset FGR at a false positive rate of 10%. So what is the pros of evaluation of first trimester screening? Basically, you have early detection, you can do early interventions, and these are useful in very special situations like ART, multiple pregnancies, and recurrent pregnancy losses. Of course, there is a small risk of false positive rate, and you need skilled personnel and expertise for that. And unfortunately, in our setup, most women present in the second trimester. So this is the inverted pyramid of care where we are working here, where you look at the 14 to 18 weeks ultrasound, you do all these markers or aneuploidy anatomy, and then you call them later, and then you assess them accordingly in the further trimesters. What about gestational diabetes mellitus? This is the latest one. This is a study which showed that universal screening during the early weeks of first trimester. And if you do, this is by Seshaya et al., said that if you do a 2-hour postprandial of more than 110 during the 8th to 10th week of pregnancy, that would predict the risk of gestational diabetes in these pregnant women. And if they are at high risk, we can start them at metformin and prevent gestational diabetes. What about the newer horizons? There have been studies that increase first trimester insulin, decrease first trimester PAPE, and TNF can also predict gestational diabetes mellitus. So this is another one which has come up in the recent studies about glycosylated fibronectin, which improves the first trimester prediction of preeclampsia. It's a bedside test. It's a point of care device, and that can be added. Studies have shown that that can be added as a fourth biomarker to the fetal medicine, to the already triple test, which increases the sensitivity. So the first trimester, to put it all in a nutshell, is a crucial window of opportunity. You can take a detailed history. You can appropriately pre-test counsel according what is available, show the advantages and limitations. The counseling has to be non-directive, and you must explain to them that screening cannot identify all affected pregnancies, and some anomalies can evolve late. So you have to have a checklist, and most importantly, have an institutional protocol as to what is available in your setting, because a lot of them is limited by economic, technical, and staff resources. Thank you so much for your patient hearing.
Vandana ma'am.
Thank you. If there are any questions, I'm happy to take. Thank you, Monica.
Thank you, Sita, for brilliant presentation.
Thank you, ma'am.
Dr. Sita, what do you think about the preconception counseling?
Oh yes, that is the most important. In fact, unfortunately, we don't get women in that age group. But a lot of these conditions, if we can counsel them preconception, like diabetes, like thalassemia, like even hypertensive disorders of pregnancy, the chronic hypertension, a lot can be predicted a lot can be avoided by the time the patient comes. Even in terms of genetic conditions, if we, by the time we do the test in the first trimester, the reports take 4 to 6 weeks time to come to. A lot of time is wasted and all that. So preconception is a major part of, should be a part of antenatal care. It shouldn't begin when antenatal period starts. It should begin before that.
Thank you. Any
so much, ma'am.
question?
Yes, ma'am. Any further questions?
Sure.
Thank you, Sita ma'am, for joining us even in your busy schedule, and Vandana madam for chairing this session. We now move on to next scientific session, that is menopause and HRT. The chairpersons for this session are Dr. Supriya Jaiswal madam and Helen ma'am. Can we have the CVs, please? Dr. Supriya Jaiswal madam is the chairperson of the Adolescent Health Committee. She has been the vice president of the Patna OBGY Society, the joint secretary of Fogsi and Bihar and Jharkhand chapters, the chief consultant at SM Hospital, Pune. She has been an executive body member of various bodies. We welcome you, ma'am.
Thank you. Yeah.
Can I also introduce Helen, ma'am? She is a professor at Jawaharlal Nehru Institute of Medical Sciences at Imphal. She's an in charge gynecological oncology department and she is a member of various organizations. She's also an accredited trainer for ISCCP colposcopy training course, and she has organized various camps and workshops for cervical cancer screening. We welcome both of you to chair this session by none other than Dr. Anita Singh madam on menopause and HRT.
Thank you, Dr. Monica. Madam Supriya, can you go ahead and introduce?
Yes, it will be a privilege for me. So good evening, everyone. And I thank the organizers, especially Dr. Priyankur, Dr. Monica, and Stabdi, all of you, for inviting me to chair this important session, to chair my teacher's session itself. Dr. Anita Singh madam, she's ex-professor Patna Medical College and vice president. She had been of Fogsi in 2020 when she had done a huge amount of work during her vice presidential tenure. She is president at present. She is the president of AOGS BJ, chairperson of IAGE Bihar chapter, chairperson endocrinology committee in year 2014 to 2016.
Okay, Supriya, that is enough.
And past president POPs. So welcome you, madam, for your wonderful presentation. Welcome you, madam. Over to you.
Good evening, everyone. First of all, I want to thank my chairpersons, Dr. Supriya and Dr. Helen, and the organizers for this opportunity. And they have included varied subjects, right from the screening. Now we have come to a subject in gynecology, that is menopause, so extreme apart from the topic which was there before. So, can I share my slides?
Yes, madam. Yes.
Yes, ma'am, please.
Yes, ma'am.
Okay. I don't know why it is not showing my desktop.
Ma'am, just on the bottom side, there is a green button, share screen. Click on that.
Yes. Yes, I have already clicked on that.
There is another window will get opened. In that, your presentation might be visible. Just click on that presentation and
Okay,
click share.
okay. I think I have not opened up my presentation. That is why this problem is there.
Yes. Yes. Ma'am, make it full screen. Yes.
Yeah, yeah.
Click on that. Yes, ma'am.
So
Perfect.
the topic given to me is menopause and ART. Menopausal hormone therapy have evolved over the last few decades, guided by the changing understanding of the treatment's risks and benefits. It was generally accepted as appropriate and safe for treatment of menopausal symptoms, as well as it was also used to prevent certain chronic diseases like cardiovascular disease. But in 2002, WHI results showed increased risk of breast cancer and CVD in women who were taking hormones, and these women were taking combined equinestrogen and medroxyprogesterone. And this result led to HRT scare in the society. Women stopped taking it and practitioners stopped prescribing it. So today I'm going to describe when HRT should be given, why it should be given, what sort of HRT should be given, and for how long, as well as the associated complications that we can apprehend and explain to the patient. And we must know about the contraindications of menopausal hormone therapy. Most of the menopausal symptoms are vasomotor symptoms, which occur in about 70 to 80% of menopausal women. The second most common for which hormone therapy is given is GSM, that is genitourinary syndrome menopause. And many times it is also given to the patients to prevent bone loss. So the improved understanding of the risks and benefits of hormone therapy, organizations across disciplines have published their guidelines, including our own institutions, which support the initiation of hormone therapy for symptomatic women who are within 10 years of menopause and under age 60 without any contraindication. So there are so many clauses which are there in this sentence that indicates when HRT can be given. The recommendation is to use an individualized approach when treating symptomatic menopausal women with periodic re-evaluation, which includes the appropriate type, dose, formulation, and route of administration that meets the treatment goal for the patient concerned and for the duration that she needs it. So there was a WHO trial in 2002, and there was a smooth sailing ship of HRT, which met with the iceberg. And what happened as a result? These women were given, this was a randomized controlled trial, 161,809 women were selected, and they varied between age of 50 to almost 80 years. So look at the age at what it was given, and there were 40 centers that did this trial in USA. And this trial showed that there was decreased risk of colorectal cancer in these women. Hip fracture risk was reduced, but it was seen that breast cancer cases increased, type of stroke increased, and there was also increased risk of myocardial infarction in these women. So there was a great scare. Then further sub-analysis of the reports were done, and that revealed that this happened because older women were recruited in the study. There was no increased incidence of breast cancer in the estrogen arm only. So again, people started realizing the fault that was there in that trial. So it was seen that between age 50 to 59 years, first year estrogen use improved blood lipids. In older age, there was increased incidence of MI. So that is why the timing hypothesis came, then when it should be given. Prothrombotic effect of estrogen will add to the already formed plaques in vessels at an older age. And that is why these women had more myocardial infarction and strokes incidence. So coming to the menopausal hormone therapy, it can be given either estrogen alone or estrogen and progesterone combination. Continuous, sequential, cyclical, there are so many ways by which we can give. Or you can give selective tissue estrogenic activity regulator like Tivolon. And a recent development in this field is tissue selective estrogen complex. That is a combination of bezodoxepine and conjugated estrogen. I don't think this is available to us. At least I do not have any experience of using this molecule. Macronized estradiol can be given 1 to 2 milligram daily, or estradiol valerate 1 to 2 milligram daily is given, usually prescribed estrogen. Whenever uterus is present, progesterone should be added to estrogen. It should never be given alone as a hormonal therapy. Progesterone can be given. There are various types of progesterone which are available to us: oral, in the form of gel, in the form of injection, intrauterine device, vaginal gels also. So medroxyprogesterone, extensively it has been used, norethistrone, norethindrone. Dydrogesterone is a favorite progesterone now being used, and micronized progesterone is also being used very frequently in menopausal hormone therapy. Routes of application and doses of different type of estrogens are conjugated, and the equivalent dose of each type of estrogen is conjugated equine estrogen 0.6 to 5 milligram is equivalent to 17 beta estradiol 1 milligram, ethinyl estradiol 0.005 milligram. So you can think how much extra estrogen woman is taking whenever she is on a pill. So pill is not an ideal drug for menopausal women. It gives very high dose of estrogen, and that can lead to problems. Transdermal preparations are available in which 17 beta estradiol patch dose is 0.05 milligram each application. 17 beta estradiol gel 1.5 milligram is provided when you give 2-meter dosage to the women. Vaginal can be given conjugated equine estrogen, and 17 beta estradiol is also formulated for vaginal use. So these are the different estrogens which at the moment we are using in menopausal hormone therapy, and we know about the doses of each estrogen which is sufficient for treatment. Now comes the dose of progesterone. Medroxyprogesterone, if it is given daily, 2.5 milligram. If it is given cyclically, then 5 milligram. Norethistrone is usually not given. Dydrogesterone is given in the dose of 10 milligram. Micronized progesterone can be given daily 200 milligram or cyclical 300 milligram. Vaginal progesterone, also micronized progesterone can be given, progesterone gel can be given, and intrauterine system also protects the endometrium, which is the main use of progesterone in the hormonal therapy. So these are the different progestogens which can be given in hormonal therapy. Regimen of estrogen and progesterone can be cyclical, 1 to 25 days estrogen, and for last 10 to 14 days progesterone. But the patient will have cyclical bleeding with this type of preparation. Cyclical combined can be given, both the drugs, right from day 1 to day 25. Continuous cyclical can be given, continuous estrogen, and every month for 10 to 14 days progesterone. Continuous long cycle can be given. There can be a gap at 3 to 6 months interval so that the patient does have withdrawal bleeding. Continuous combined can be given, or intermittent combined can be given to them. So there are different ways of giving estrogen progesterone combination whenever it is used for hormonal therapy in postmenopausal women. Now, what are the risks of oral estrogens? The risks are because of the first pass metabolism through liver. There is increased production of coagulation factors and various inflammatory markers. There is hypertriglyceridemia, elevated risk of venous thromboembolism, more chances of formation of gallstones. So, transdermal and topical estrogens bypass first pass metabolism. That is the advantage of non-oral estrogens. So, transdermal menopausal hormone therapy does not modify markers of coagulation, more favorable effect on triglycerides, does not increase incidence of stroke. It eliminates hepatic first pass metabolism. Much lower dose of hormone therapy will successfully alleviate the symptoms and provides a more consistent level of hormones. There is no increase in SHBG, and thus these do not reduce bioavailability of testosterone, which is useful in women, especially who have diminished libido. What are the chief indications for menopausal hormone therapy? Estrogen alone therapy is given in the hysterectomized patients, and in patients who have their uterus intact, estrogen combined with progesterone is given, chiefly for management of moderate to severe vasomotor symptoms. Prevention of osteoporosis in women who are unable to tolerate standard medications. So first choice will be the other medications to prevent osteoporosis, not hormonal therapy. Tissue-selective estrogen complex, that is Tibolon, indications may be the same as above, but it is especially useful in those cases who have breast tenderness, increased breast density, or uterine bleeding with estrogen progesterone therapy, breakthrough bleeding. Low-dose vaginal estrogen therapy is given for the treatment of genitourinary symptoms of menopause, vaginal dryness, dyspareunia, etc. Progesterone stimulates the lobular system of the breast. Estrogen stimulates the ductal system. So it has been seen that the breast cancer risk was increased in women who were given estrogen and progesterone. So it was conferred that progesterone is a risk factor for breast cancer, which contributes to cell proliferation in breast cancer. So is there a difference in the various progesterones used in hormone therapy? One side does not fit all. So the risk of breast cancer was higher with medroxyprogesterone acetate, levonorgestrel, and norethiosterone. Lower with dydrogesterone, even for more than 5 years. The excess risk dissipated in the past users of progesterone. There is better sleep with natural progesterone. Continuous combined equinestrogen, 0.3 milligram daily with progesterone, natural progesterone 100 milligram provided significantly better sleep outcomes than medroxyprogesterone with CE. Twice weekly progesterone gel also can be applied vaginally. Lesser dose is required to act on endometrium. More drug reaches through good network of vessels from vagina. So there are lesser systemic side effects. In the consensus of Indian Menopausal Society says that estrogen progesterone therapy more than 4 years is associated with the risk of detection of carcinoma breast. But it does not appear to initiate malignant transformation. It actually only potentiates it. And carcinoma breast detected during HRT use usually less aggressive with more favorable prognosis. So there is a perception that there is increased risk of breast cancer within a short duration of time. But the evidence says that after 5 years use of combined estrogen and progesterone, the WHO cohort showed a small increase in risk of breast cancer of about 8 extra cases per 10,000 women who were given this hormone for the first time. The risk is associated with long-term estrogen use is much lower than the risk conferred by obesity, inactivity, and alcoholism. What are the side effects? Increased factor VIII, increased deep vein thrombosis, dry eyes, increased headache in migraine, oral estrogen, increased triglycerides, melasma, macular pigmentation, drug dependence, transdermal estrogen decreases triglycerides, increases microalbuminuria, Sjogren syndromes, but these are rarest of the rare complications that side effects of estrogen and progesterone. Breast tenderness and bleeding is sometimes there. Then the estrogen dose should be reduced. Sorry. So if there is breast tenderness and bleeding, then the dose of estrogen should be reduced. In cases of irritability, depression, water retention, and headache, the dose of progesterone should be reduced. So we should be very clear about the problem that the patient is having. Breast tenderness, reduced estrogen dose, change progestin, restrict salt intake, cut down on caffeine and chocolate. Sometimes mild gastrointestinal disturbances like nausea and vomiting can occur. So estrogen should be asked to be taken at night. So because of all these side effects, there was a need for a drug that will not stimulate the endometrium, that will not stimulate the breast, a steroid that is tissue specific and do all that estrogen can do. Then came in 1989 when Willett started extracting tibolone, and its hormonal profile showed that it was a selective tissue estrogen activity regulator. It is more metabolized quickly to 3 active metabolites in the liver, that is estrogen, progesterone, and androgen. Action of tibolone, it reduces flushing and sweating, reduces bone reabsorption, improves karyopyknotic index in vagina, reduces atrophy, improves dryness and dyspareunia, improves mood and libido. And it also improves sleep. It prevents loss of muscle strength, improves lean body mass, decreases proliferation rate in breast epithelium, increases apoptosis, induces endometrial atrophy by progesterogenic action. So it has got so many benefits. It also lower levels of but there is lowering of high density lipoprotein cholesterol, as well as, but there is decrease in fibrinogen and factor 7 activity, increase in antithrombin 3 and plasminogen, with an overall trend toward increase in fibrinolytic activity. A status of cardiovascular protection from tibolone is not yet established. Dose is 2.5 milligram per day. But it should preferably be started 1 year after menopause. Then there will be less chances of abnormal bleeding. If bleeding occurs, reassure unless the bleeding is excessive or endometrium is more than 5 millimeter. Tibolone increases the risk of a stroke in women more than 60 years. Use with caution in women who have a history of stroke. Tibolone may decrease body fat, increase fat-free mass and total body water. Weight gain should not be a concern with the women taking tibolone. When other symptoms predominate, insomnia, nervousness, disinterest, fatigue, loss of concentration, that is all indicate androgen deficit syndrome, tibolone can be a good choice for hormonal therapy in menopausal women. It has shown itself to be superior to conventional hormone therapy in women with surgical menopause. It can be an alternative to conventional therapy for the treatment of postmenopausal women with sexuality changes. How long estrogen can be used? In premature age, at least up to the natural age of menopause. Natural and menopause, estrogen plus progesterone Safety data for 3 to 5 years. Estrogen only, the safety data is for 7 years. How long to give? Less than 5 years will be enough in very severe flashes. How should this patient should be cared after initiation of therapy? 1 month, 3 months, 6 months, yearly, as appropriate for the patient. We should look for adequate symptom control, timing, and acceptability of withdrawal bleeding. Also, we should look for side effects, look for weight, blood pressure changes, and answer any query by the patient. 6 month or 1 yearly lipid profile, hormone profile, clotting profile should be done. PB examination, transvaginal sonography, endometrial biopsy if the endometrium becomes thick, breast examination and mammography routinely, and BMD measurement if indicated. 2 to 3 yearly biopsies if indicated, pap smear or nowadays HPV DNA, mammography, family history of breast cancer should be done more frequently. What are the contraindications for menopausal hormone therapy? Absolute contraindications are acute endometrial breast cancer, acute phase myocardial infarction, undiagnosed breast lump, undiagnosed abnormal vaginal bleeding. Other contraindications are primary CVA, acute phase pulmonary embolism or DVT, recurrent thromboembolism on contraceptives, spontaneous thrombosis, inherent abnormalities of coagulation like antithrombin 3 presence, fibrinogen, and platelets. Risk-benefit analysis of menopausal hormone therapy has shown that it has got estrogen and estrogen plus progesterone. Both are beneficial in vasomotor symptoms. In osteoporosis also, both are beneficial. Coronary heart disease, there are both risks and benefits. Benefits are there in women less than 60 years of age, not predisposed for coronary artery disease, and the risks are there in women more than 60 years of age. In a stroke, estrogen progesterone in less than 60 years, it doesn't have much effect difference between the two groups. But after 10 years of menopause, both estrogen and the combination has got definite risk, increased risk. Diabetes, it is beneficial. It prevents type 2 diabetes mellitus, and also in established diabetic patients, the hormone therapy leads to decrease in the dose of insulin. But it has been seen that all venous thromboembolism, there is definite risk with either form, alone estrogen or estrogen progesterone. It has been seen that all-cause mortality at the end is not different in the group of women. In the cancer, breast cancer, estrogen alone, progesterone increases the risk. Estrogen is beneficial. Endometrial cancer, progesterone alone has got bad effect, whereas if it is given with progesterone, long-term use of OCP in the past leads to benefit in the reduction of endometrial cancer incidence. Colon cancer also, there has been seen that these women have lesser incidence of colon cancer. Fractures, there is definite risk of both the types of menopausal hormone therapy. So to conclude my talk, I have to say that hormone therapy is the most effective treatment for the vasomotor symptoms of menopause, which are common and can adversely impact a woman's life. It is clear now that the safety of hormone therapy depends on a woman's age and duration of time since menopause, such that the benefits tend to outweigh the risk in healthy women less than age 60 or within 10 years from menopause. Selection of formulation and duration depends upon indication, risk factors, contraindications, and patient profile. Thank you very much for patient hearing.
Over to you, Supriya ma'am, for your comments.
Thank you, madam. Thank you for your elaborate talk. And you have rightly said that you have summed up everything right from the definition to how we are using the HRT, and then in menopause, what all precautions we should take and what are the side effects. So you have summed up each and every part of the talk, and very well. I think the audience must have benefited a lot from this, madam. So thank you so much. Dr. Helen, you want to say something? Dr. Helen is also there. Okay. So, Monica, you can carry on. Is there any questions? No questions, I think.
Ma'am, I'd like to share an input.
Yes, we are asking for that.
Yeah, actually my laptop just conked out, so I had to log in from my mobile again immediately.
Okay, speak up.
Thank you so much, Anita ma'am. It was like really nice and like so, I mean, it covered so many aspects. Partly in my clinical practice, because I deal with oncology cases. So I was just thinking, because nowadays we are getting so many patients in younger age group where we have to do radical surgery, which sometimes calls for removal of ovaries in very young patients. So this aspect of hormonal therapy is especially useful when we are considering those young patients with cervical cancer, but those hormone-based cancers are a bit of a problem. So I think more studies, in fact, needs to be done, especially because, Madam, you yourself pointed out, one size does not fit all, and nowadays the concept is about tailoring. So thank you so much, ma'am. It was really nice, and I think we all should, try to put together and think on that concept also. Thank you so much, ma'am.
Thank you, Dr. Helen and Supriya. Thanks a lot.
Thank you, madam.
Thank you,
Thank
ma'am.
you.
Could I just
Yes.
ask another question? This is in relation to Dr. Helen's point. If the malignancy is hormone dependent, so wouldn't it be easier to treat with the anti-hormones? Like suppose it's a breast cancer, which is hormone dependent, then it is easier to treat that vis-a-vis which is not hormone dependent.
Like for instance, let's say we are dealing with endometrial.
Can I say something?
Yes, ma'am.
Yes, madam.
Actually, the hormone-dependent tumors are better ones with prognostic point of view, because they are to some extent differentiated tumors, and when you give the anti-hormone, that is more susceptible to that. It is true for endometrial carcinoma as well as for breast carcinoma. We only know much about these two cancers. So I think those are the better tumors out of the different other types of tumors of that organ.
Exactly.
Yes.
I have a question, ma'am. Ma'am, the market is flooded with soya isoflavone and so many non-HRT products. What is the role of those molecules in menopause and HRT?
Very good question. Actually, I was expecting that to be asked. Actually, you see how much research has been done and how much work that which hormone affects what type of lipids, this and that. If you look at the phytoestrogens and isoflavones, those are not the molecules which have been researched so well. So we are not yet sure. Even if they do have estrogen, we know that estrogen has got so much of bad effect also. So are you going to supplement with progesterone, or you are going to give it alone? So I don't think that is very scientific to give all those drugs for a very long period of time. Of course, you can give it for very short period of time if you really want to avoid any pure estrogen or progesterone. If the patient does have contraindications, we can give for a short period of time, but I don't think that those drugs should be given because you don't know even about the efficacy of that drug. The rest of the drugs have been compared regarding the efficacy. What should be the dosage to be equivalent potency, to have equivalent potency.
Sure. Thank you, ma'am.
Yes.
So to Helen,
Thank you,
after
Anita ma'am.
radical surgery,
Hello, ma'am.
hello. How
Hello.
soon you start the estrogen therapy? After radical surgery, how soon you start?
No, ma'am, so far, I mean, it's all about counseling, and we tend to go more for keep more hormone therapy, more for palliative care basis. So with 5 years of experience so far, we haven't had a chance to counsel yet. Some patients do come, and we opted more for non-hormonal like yoga and all. We advise them to have
Non-patient removing the ovary. What is Anita madam's perspective regarding this?
Which cancer you are talking, Dr. Sasmita?
Suppose cancer cervix or cancer ovary, young patient, we are removing the ovary, or if there is family history, we are prophylactically also we are doing oophorectomy in some cases. So after surgery, we should start early because there will be
Yes.
sudden loss of hormones and there will be sudden symptoms they will develop immediately. They come.
I think the only in ovary and cervix, the only contraindication to giving estrogen is only the side effects of insulin that you estrogen that you are going to apply, thromboembolism and all that, thrombosis. So once that period is over, in my opinion, one should start giving her hormones, estrogen.
Yes.
I'd like to give one more input here also. I mean, right nowadays, especially we are considering fertility preserving option surgery so much.
Yes.
But when we talk about that aspect, we have to remember that we are talking about hormone status also. So there has been cases when after proper evaluation, if I feel it's an early stage disease, I have so far done 2 ovarian transposition in a case of CS cervix, because I was not very sure. I mean, after reports, of course, they were found to be in early stage, so I did not have to go for adjuvant radiotherapy. Might be required if hormonal therapy is required. So putting that perspective, I have always tried to do ovarian transposition, and I have done 2 cases, and so far the follow-up has been good. Patient did not complain of any menopausal symptoms, and the both ladies were in their mid-30s. So that so far that has been my experience. So it's not only about hormonal replacement as such, but we can preserve ovaries, especially in cases of CS cervix. And for those young patients with endometrial cancer, ovarian cancer tends to be more of a hereditary reflection also. So those cases we have to tailor proper, tailoring of the cases and follow them properly and do what is required.
So I think along with this HRT, we also have to counsel the patient regarding the lifestyle modification.
We do that.
They should have a regular exercise, sun bathing, and soybean. That is also
Soya-based diet. Ma'am, yoga is a wonderful thing if one can stick to
that
it.
also we have to advise them. Yeah, that is also very important.
Yes, ma'am. Thank you.
If the uterus is not there, very easily we give hormone. But once uterus is there, we are little reluctant to give hormones.
Exactly.
Okay. Very nice,
Thank you, Helen ma'am, Supriya ma'am, and Sasmita ma'am for your excellent inputs. Thank you, Anita ma'am, for joining us for this academic session. I hand over to Dr. Shatabdi to carry forward the next session.
Very good evening to everyone. After those 2 brilliant lectures by Dr. Sita ma'am and Dr. Anita ma'am and a brilliant discussion by our chairpersons and the speakers, we move on to the next session. Our next session today is a panel discussion on management of abnormal uterine bleeding in perimenopausal age group. We have 2 very dynamic moderators with us, Dr. Vinita Singh ma'am and Dr. Nivedita Datta ma'am. And the expert today is Dr. Shashmita Shrain ma'am. Can we have the CVs, please? Yeah. Dr. Vinita Singh ma'am is an associate professor in the Department of OBGY at Patna Medical College, also a consultant at Care Hospital and IVF Center. She is also the East Zone coordinator of Fogsi. She has held various posts in the earlier period, including the chairperson of the YTP committee of Fogsi.
Thank you, Shatabdi. Thank you very much.
Yes. Welcome, Vinita. Welcome, Vinita ma'am. Our next moderator is Dr. Nivedita ma'am. Ma'am is a consultant at Bokaro. She is also the president of the Bokaro Obsgynae Society and the East Zone coordinator for the Safe Motherhood Committee, as well as the Manyata coordinator.
Thanks.
Welcome, Nivedita ma'am. Yeah. Our expert today is Dr. Shashmita Shrain ma'am. Ma'am is a professor and unit head at SCB Medical College and Hospital, Cuttack, ex-professor and HOD of Bhima Bhoi Medical College and Hospital. Ma'am also has been the honorary secretary cum treasurer of AOGO, Odisha. Welcome, Shashmita ma'am. We're looking forward to your input. We have 8 panelists with us today. Our first panelist for the session is Dr. Kavita Burnwal ma'am. Kavita Burnwal ma'am is a senior consultant and laparoscopic surgeon at Samarpan Hospital, Munger, associate professor at Lord Buddha Koshi Medical College, as well as the member of the YTP committee of Fogsi. Welcome, Kavita ma'am. Our next panelist is Dr. Devanjana Datta ma'am. Ma'am is the secretary of Silchar Obsgynae Society, working as a consultant in a women's hospital, the oldest in southern Assam. And she also has been the office bearer in various capacities in the local society. Welcome, Devanjana ma'am. Our next panelist is Dr. Ronita Roy Chaudhary. She is an associate professor in College of Medicine and J&M Hospital at Kalyani, and also the president of the Kalyani Obsgynae Society. Welcome, Dr. Ronita. Our next panelist is Dr. Shubhabrata Sharkar ma'am. Ma'am is an assistant professor at COM and J&M Hospital at Kalyani, also the secretary of the Kalyani Obsgynae Society. Welcome, ma'am. Our next panelist is Dr. Sudha Jha ma'am. Ma'am is a senior gynecologist and head of MCH unit at Sadar Hospital, Sitamarhi. She also is the scientific secretary of Fogsi, Sitamarhi. Welcome, Sudha ma'am. Our next panelist is Dr. Shantwana Sharan ma'am. Ma'am is a consultant gynecologist, also the immediate past convener of the National IMA MPH. Ma'am is has been the vice president of the East Zone Women Doctors Wing in 2022, as well as the National IMA convener in 2021. Welcome, Shantwana ma'am. Our next panelist is Dr. Sadhana Kumari ma'am. Ma'am is the director of Sadhana Hospital, Dhanbad, as well as the former secretary of Dhanbad Obsgynae Society. She's participated in various panel discussions and she has been working on anemia and female feticide under the banner of Lado Rani. She's the founder and secretary. Welcome, Sadhana ma'am. Our next panelist is Dr. Ekta Verma. Dr. Ekta is a senior resident at SMS Medical College, Jaipur. She also is the member of MOGS and consultant obstetrician and gynecologist at EVA Hospital, Gaya. Welcome, Dr. Ekta. I now hand over to Dr. Nivedita and Dr. Vinita ma'am for carrying out the panel. Thank you, ma'am.
Thank you, Dr. Shatabdi. It was very, very nice introduction from your side. Very good evening to all participants of today's program. At the very outset, I would like to thank Dr. Priyankur Roy, who's a dynamic chairperson of Public Awareness Committee, to giving me opportunity to moderate such a wonderful session, panel discussion, along with a very dynamic co-moderator, Dr. Nivedita Datta. And the topic is really wonderful, that is abnormal uterine bleeding in perimenopausal age group. In our day-to-day practice, we are always encountered with this type of cases, and be it may occur in adolescent age group, reproductive age group, and perimenopausal age group. So really it's very challenging because we have to customize the treatment according to the need of the fertility and according to the age. So it's really challenging, and we all say that challenges are what makes life interesting and overcoming them is what makes life meaningful. So we take this challenge and we treat the patient a customized in a customized way is that what we are meeting challenges. So there are various evidences and guidelines, and according to our experience, we have to treat. Whenever we think of treating a patient, we have to see that what the age group she belongs, and we have to see her future fertility also, and we have to give the basket of treatment. So these are the treatments is there, and we have to allow the patient to choose according to her need. So we have in this, we have to counsel the patient, and we have to go with with the patient also. So next, Nivedita, because it's with you. So now coming to the topic. We are talking about abnormal uterine bleeding, and we are also talking about dysfunctional uterine bleeding. So, Dr. Devanjana, can you define what is abnormal uterine bleeding and differentiate between dysfunctional uterine bleeding and abnormal uterine bleeding? This question goes to Devanjana. Is she here? Dr. Ekta? Dr. Ekta? Dr.
Am I audible, Vinita? Hello, am I audible? Hello?
Yeah, yes, yes.
Hello?
Yes, Dr. Ekta, you're audible.
Yes.
Yes, Ekta, are you there?
Yes, ma'am.
Yeah.
Can you repeat the question, ma'am? Sorry, I didn't hear that question.
Your question was definition of abnormal uterine bleeding.
Okay. And abnormal uterine bleeding is actually any deviation from the normal pattern of bleeding, menstrual bleeding in a female. It can be in terms of frequency, in terms of amount of bleeding, in terms of whether it is cyclical or non-cyclical. These are the main factors which differentiate abnormal uterine bleedings are defined like this.
And can you differentiate between AUB and dysfunctional uterine bleeding? What is the
dysfunctional uterine bleeding mainly comprises of ovulatory causes of abnormal uterine bleeding, and this is the main difference.
So I think Kavita is there. So can you classify, Kavita, the abnormal uterine bleeding?
Yeah. So any bleeding that is abnormal in amount, duration, and frequency either in the pre-pivotal age group, in the pivotal age group, in the adolescent age group, in the reproductive age group, that is variant from the normal bleeding. So Vinita just I have come from OT, so I have not gone through. Anyway, so that is abnormal uterine bleeding, and I think we can classify as anovulatory or ovulatory. And recently, FIGO has classified causes of bleeding, organic and inorganic causes. So I think this will be better classification. So we can classify as structural as well as functional causes. And structural includes PALM, that is polyp, adenomyosis, leiomyoma, malignancy, and while functional includes any type of coagulopathy, any sort of ovulatory dysfunction, especially in PCOS cases or in late reproductive age group, any pathology of the endometrium, or sometimes certain iatrogenic causes, like when we give certain drugs that can cause abnormal uterine bleeding, and sometimes the classification remains unknown, and that is named as not yet classified. So I think this FIGO classification is better rather than earlier what we used to say hypomenorrhea, oligomenorrhea, hypermenorrhea, menorrhagia. So I think this will be better classification.
Yes, Kavita, so you're right. So palm coin classification is a better one. It's a very easier one also. So now as expert, we are having Professor Sasmita Swan. So if a patient comes with abnormal uterine bleeding, she is having heavy bleeding, or she is having scanty menses, or it's a very frequent in nature. So they are, they are distressed. So what are the effects of abnormal uterine bleeding, ma'am? Can you describe, you must be having so many patients in your practice. So can you tell me what are the feelings they have and what are the problems? What is the psychological effect? What are the effects she feels?
Good evening. First of all, I thank the Public Awareness Committee for giving me this opportunity, and thanks to Dr. Priyankur also. Before the last question, I think the DUB word is now obsolete. No more DUB is used.
Absolutely. Absolutely.
Previously, it was told if there is no organic cause, then it is termed as DUB. And it is now the AUB has included all types of bleeding. And they are divided into structural, which can be diagnosed by the imaging modalities or from the histopathology. And the other one is the functional, which by the history from investigation from those things we can diagnose this. That is that. And coming to the effect of AUB, I think this type of irregular bleeding definitely affects the quality of life in relation to her social, their emotional, their psychological, the marital lives, the religious things, what she wants to do. And also, she feels very depressed sometimes because there is anxious regarding the malignancies. Women are very much anxious for that. So all types of AUB we have to investigate. And due to the anemia, they suffer. So many times they do not know these abnormalities are abnormality. So many times they do not come forward for treatment. So this awareness also we have to create. What is the normal menstrual cycle, and what is the abnormality, when they should come forward for treatment. Because many times you get patients who are very severely anemic, only then they come. So that is, as a healthcare providers, we have to bring the awareness among our women that any abnormality should be treated, they should come forward for their treatment.
Yes, absolutely true, madam. They are psychologically upset, especially in the perimenopausal age group. They feel that they will be having cancer. So carcinoma is something, they are so afraid. So definitely whenever they have any irregular period, they should come to the consultants, and we are there to treat her. So thank you very much, ma'am, for your input. So now coming to the case scenario, there is a female 46 years old complaining of heavy and painful periods. Now the catch point is heavy and painful periods for last 2 years. Cycles are of 5 to 6 days. and duration is of 5 to 6 days, and cycle is of 18 to 23 days with heavy flow. Vitals is stable. She's a bit overweight, 70 kg, and hemoglobin. She is a mild anemic, 9 gram person. And according to transvaginal sonography, uterus is uniformly enlarged. Size is 10.2 into 7.2 into 6 centimeters. Myometrium shows a mottled inhomogeneous texture and had small cystic spaces within the myometrium. And endometrium is shaggy in nature and is 9 millimeter. Right ovary shows a small hemorrhagic cyst of 1.1 to 2 centimeter, and everything rest is normal. So I would like to ask Dr. Santwana Sharan, you are there? So can you tell me, saying this, what is the diagnosis and what is the ultrasound finding in this, ultrasound finding? Ultrasound is there. So what is the finding? What is the pathology you can see from this?
Yeah, ma'am. Thank you so much, ma'am, for giving me the opportunity to join this session. Ma'am, as it is written, TVS shows the uterus is uniformly enlarged and the size is 10.2 to 7.2 to 7.2 centimeter into 6 centimeter. Myometrium shows mottled inhomogeneous texture and has lots of cystic spaces within the myometrium. The endometrium is shaggy, distinct, and 9 millimeter. All these shows, ma'am, it's suggestive towards adenomyosis of the uterus. This is very common in this age. And by the ultrasound finding and by the complaints of the patient, we can think of adenomyosis here.
So, okay, you're right. So, Dr. Ranita, now she has told that this is a case of adenomyosis. Any other investigation you would like to do for this patient?
Yes, actually, there's some disturbance, I guess. Actually, ma'am has already quoted that there is a we can go for TVS, and after that we can also go for 3D ultrasonography, saline infusion sonography, and hysteroscopy, and maybe MRI. But the first option is always the transvaginal sound. In case we suspect that there is some intracavitary lesion or something like that, then we can do a 3D ultrasonography, and similarly, saline infusion sonography is also helpful for those intracavitary or submucous one. Even Doppler ultrasonography, we can look for the changes like malignant transformation or AV malformations and like that. For that, we can go for the Doppler ultrasonography.
Vinita Di, can I add one point? Can I add one point, Vinita Di?
Sure, Kavita. Okay, no problem.
Actually, I think TVS ultrasonography, if someone is perfect, can diagnose adenomyosis clearly, because there are certain features like loss of endomyometrial junction. There will be breakage. There is rain in forest or salt and paper appearance. These are the findings which are consistent with adenomyosis. Cystic spaces is also consistent with adenomyosis. Color Doppler can distinguish. Sometimes localized adenomyoma can be confused with the pleiomyoma. But at that time, color Doppler will help whether it is just bleeding around the lesion, that is in leiomyoma, while in adenomyoma, the vascularity will be all around. So I think TVS is enough to diagnose if we suspect some other pathology, like polyp or something else, or endometrial hyperplasia. Then we can go for MRI or SIS or anything else. So I think TVS with color Doppler is enough to diagnose adenomyosis.
I think, Kavita, you're absolutely right. In a day-to-day practice, we are going for TVS only. We are not going for MRI. But if there is any confusion, only then we go for MRI. If we are not, confirmed with the diagnosis of the adenomyosis. In that case, only we go for MRI. Otherwise, TVS and color Doppler is more than sufficient. So as expert, I would like to ask Madam, now this is confirmed that she is a case of adenomyosis. Now, what should be our aim? How should we proceed with this case, ma'am? Can you give me some input in this case?
As per the investigation, from the history itself is suggestive of adenomyosis because it is dysmenorrhea and with heavy menstrual bleeding. Fibroid is usually less painful. So according to her complaints, we have to treat her. Her age is, she has completed her family. So we have to relieve her symptoms. If fertility she desires, then according to that, we have to go for the treatment also. And as we know, adenomyosis does not respond to the oral therapy much, but today Mirena has come as a boon for adenomyosis. That is the level 1 choice for adenomyosis. We can give Mirena in this patient. Uterus is not very big, cavity is not that much distorted. So if possible, we can give Mirena to this patient. And also relieve our symptoms and correction of anemia is very important, that also.
So now the patient who is anemic, the hemoglobin is 9 gram%. She is, she is having severe pain. She is having dysmenorrhea. She is having heavy menstrual period, and the cycle is, frequent cycles. So in this case, our motto should be to pain relief, correction of anemia, and decreasing the blood loss. This should be our. So Dr. Sadhna, can you tell me how will you manage this case? How will you proceed with this case?
Thank you, Vinita ma'am. Thank you, Vinita ma'am. And my humble greetings to all of you. Sushmita ma'am has already described all the treatment modalities. And as the patient is 46 years age, fertility is no issue. And she is anemic, having pain and excessive bleeding. So treatment is mostly guided towards symptomatic relief. And we can use medical treatment, drug treatment to decrease the blood loss like tranexamic acid, and to relieve pain we can use mefenamic acid. Oral contraceptive pills are also better choice, but as her age is 46, and as the madam rightly said, ideal treatment for in this case is Mirena if patient is agree for that, because lot of patient have confusions and they do not want for Mirena. And if her family is completed, and if the patient desire, we can go for surgical treatment. And other treatment modalities are also, but less used, like gonadotrophin releasing hormone, and agonist, antagonist, progesterone, aromatase inhibitors, GnRH agonist, etc.
So you are right, Sadhna. If there is polyp, in that case, we can go for LNG IUS, that is, most acceptable. If not acceptable, then only we will go for GnRH agonist and antagonist. I think antagonist is a better, most preferred rather than agonist, because there is more flare-up with the agonist rather than antagonist. So here we are saying this LNG IUS, this is very good. And, most of the nowadays, the elite class, the women's, they are coming with AUB, they accept this LNG IUS. So this is good. So now
the motto is to preserve the uterus. So as far as possible, don't remove the uterus, keep the uterus, give the LNG IUS. It is also very effective.
Yeah. So now, if you want to preserve the uterus, now what are the minimal conservative surgery for adenomyoma and adenomyosis? This question goes to Dr. Sudha Jha.
Good evening, everybody. And when the medical treatment fails, and if the patient is not accepting Mirena, then we come to the minimal invasive techniques. In that, and the aim is, and what is our aim? Our aim is to preserve the uterus and to remove the symptoms. For that, there is excisional adenomyomectomy to involve the complete removal of the local lesion, and myometrectomy, that is the surgical debulking of diffuse adenomyosis, and others are non-excisional treatments, in that to induce necrosis of the local or diffuse adenomyosis through selective vascular occlusion or focused ultrasound or thermal energy without direct tissue dissection.
Yeah, true, Dr. Sudha. So we are so many, we are here. So can you tell me, anyone has done this myometrectomy? What is your opinion? Have you done this, Sasmita Swan, ma'am?
No, I have never done myometry because it is not very easy to do. Where is the adenomyoma? For that, you have to be very sure where is the location. You have to go for MRI, you have to be focused, you have to know where is the myoma. Only that portion you want to remove. Because this surgery has to be done in those patients who want fertility. For those cases only, you will prefer to go for this adenomyomectomy or adenomyomectomy. I have never done this.
So yes, so I have also not done. So I was really, I thought that somebody has done. So let us, share the experience. So yeah, so this is conservative surgery we are doing. So there are three approaches. One is laparotomy, one is laparoscopy, and another is hysteroscopy. So Dr. Kavita, can you tell me about the three, what will you do in this case?
Madam, thank you. So if there is a confirmed diagnosis of adenomyoma, because we cannot treat the generalized adenomyosis by surgery, it will be dealt with, I think, generalized agonist. So that will be sufficient to treat generalized adenomyosis. But if there is localized adenomyoma, and sometimes it causes infertility and along with other symptoms, then we can go for, we have done a few cases of adenomyoma removal. We tried laparoscopically, but it was very difficult. So then we did laparotomy, but we did adenomyoma removal and thereafter patient conceived. So mostly we do, either you can do laparoscopy, one is expert in laparoscopy and especially in suturing. Then he or she can do laparoscopically also. Otherwise, laparotomy can be used to remove localized adenomyoma because sometimes it resembles as a myoma, but it remains adenomyoma and it causes infertility. Hysteroscopy can be done if there is associated some other pathology that is also towards the uterine cavity. Then only I have not done any hysteroscopy removal of adenomyoma, but laparoscopy and laparotomy we have done, and sometimes it is helpful and patient gets fertility also. So I think
expert hand, if one is very expert in laparoscopy and hysteroscopy, they can go ahead with this hysteroscopically, I mean laparoscopically. Otherwise, usually we go we do laparotomy and we go for adenomyomectomy. So the only thing should be done with very expert hand. It's okay.
Yeah, I would can I just say one thing?
Sure,
Dr.
sure.
Dr. Sunita was doing these webinars with us, and she has shown some wonderful cases where she has done a laparoscopic adenomyomectomy and how she recommends the T-shaped incision to remove the adenomyoma for suturing. This is fantastic videos she has. I'm not aware of others, but anybody who wants to see these videos, I think she has, during her tenure of when she was campaigning, she's posted a lot of videos on adenomyomectomy also. People can approach that.
So it should be done in a very expert, and I think she must be very expert in doing this adenomyomectomy. Otherwise, it's very difficult, doing laparoscopy.
Absolutely.
So now I think Suvabrata is there. Are you there?
Yes, ma'am. Yes,
Okay.
ma'am.
So any other modalities apart from this conservative surgery you can tell me to manage this case, adenomyosis?
Yeah, for newer modality, there can be high intensity focus ultrasound, where it is a non-invasive technique with no blood loss, where the ultrasound is selectively focused on the adenomyomatic tissue, not affecting the other normal tissue, which is also fertility preserving. Like there is a very good outcome after this. And another method which can be done also is uterine artery embolization, though there is ongoing trial, the Questa trial from 2026, which the result will be out hopefully. This result in necrosis of the tissue by blocking the blood supply to the adenomyoma by this uterine artery embolization.
So it's okay. It was well spoken. Uterine artery embolization we are doing. I have done 2 cases in my hospital, and it was really wonderful. Did wonderful but that was a case of fibroid uterus, not in the case of adenomyosis. So it's really good. So coming to the end of this question, I think this is the algorithm of abnormal uterine bleeding. How should we proceed? So women who is desirous of fertility and unwilling for immediate conception, I think LNG IVS is the recommended as the first line therapy should be offered to the patient. If she's not willing, in that case only GnRH antagonist and agonist should be given. And if not, then if she's having problem with this GnRH agonist antagonist, in that case we can give her combined oral contraceptive pills or progesterones. Danazol we are not giving nowadays, and NSAIDs can be given to her if she is having dysmenorrhea. In that case we can add. So if Now, women who is not desirous of fertility, first line treatment should be medical management. If not, then LNG, IUS. If not, she is not willing to have this. In that case, again, GnRH agonist, antagonist. And if is, then only we can go for, laparoscopic hysterectomy or laparotomy we can do, because usually conservative surgery I won't prefer if she is of 40 or 40 plus. So in that case I would prefer hysterectomy. So this is the algorithm and this is the modalities of treatment we will go with the case of adenomyosis. Now for the next question, I think Nivedita is there. Now so Nivedita, you can ask, go ahead.
Okay, I think we've just had a wonderful round of rapid fire question answers on adenomyosis, and Dr. Vinita ma'am has moderated very effectively. And I think between Dr. Vinita, Dr. Sashmita, and all our panelists, we have got excellent take-home messages about the management of adenomyosis. We've already learned about the gonadotrophins which are used for management, and gonadotrophins lead to hypoestrogenism. So Dr. Devanjana, if she's here, if she's not here, anybody from the other persons from the panel can take on this question.
Dr. Devanjana has joined.
Okay. Hi, Devanjana. Hi, Devanjana. Devanjana, could you just brief the audience about what is add-back therapy and what are the drugs that you are using for the same?
Add-back therapy is if we are using GnRH for a long time, there is hypoestrogen level, and so it causes osteoporosis. And to combat the osteoporosis, we are giving estrogen therapy, ICE, Pirmarin in very low dose, or estradiol 1 milligram once daily for 30 days, or combined estrogen progesterone therapy, or low dose progesterone therapy, or tibolone therapy. Some we can give, and this is the add-on therapy to prevent the osteoporosis due to low estrogen level.
Thank you, Sudha ma'am. Thank you. Very well said. And we just had a wonderful talk by Dr. Anita Singh ma'am on tibolone. Now we'll move on to the second case. We are doing perimenopausal abnormal uterine bleeding, and has been rightly said that now we are only sticking to abnormal uterine bleeding. So this is Mrs. B. She's a 39-year-old lady, para 2, living issue 2, and 1 abortion. Previous both are LSCS. Now she complains with menorrhagia and dysmenorrhea. Her last menstrual cycle was 34 days back. I mean, she's just crossed 4 days. She's also undergone a previous surgery for incisional hernia. So she's already had her abdomen opened thrice. Now, on examination, she was pale and her uterus was a 14 to 16 weeks gestational size. What are the differentials that we can think of, Dr. Ekta?
Yes, ma'am. Thank you, ma'am. The differential diagnosis for this patient would be fibroid uterus, or generalized, means as the size is around 16, as the size is around 14 to 16 weeks. So fibroid uterus we must think first, and structural causes are the main causes in this case. And the second differential diagnosis will be ovarian cysts or tumors, and third would be adenomyosis, generalized adenomyosis.
Yeah, but we should also not forget pregnancies, because she's not, I mean, I've not mentioned that she's sterilized. So, yeah, perfect.
Sorry, ma'am. Actually, gravida was not written there, so I thought that this is not a case of pregnancy. Yes, of course, pregnancy should be ruled out first of all.
No, we have to rule out. Even if it is not that, we
Yes,
have to rule out pregnancy as a
Yes, ma'am. Yes, ma'am.
Absolutely. And now, Dr. Kavita, if you could, she's already mentioned the various provisional diagnosis, so a differential diagnosis. So how do you think we can come to what is the diagnosis? What are the investigations you will do to achieve the correct decision? But among the differential diagnosis,
first of all, we have to rule out the pregnancy.
Just one thing. Menorrhagia word is also no more advisable by FIGO. It has to be written heavy menstrual bleeding.
Exactly.
HMB, HMG, yes, absolutely.
Yeah, exactly. So I think we have to rule out at first pregnancy, and thereafter we'll get her all other bleeding disorders test done. Though she's, I think, 39-year-old now. So
Yes.
I don't think there will be any bleeding disorder, but still it should be done, especially CBC and other tests should be done. Thyroid test should be done to rule out whether there is any hypothyroidism or hypothyroidism, and thereafter ultrasonography will be done. First transabdominal ultrasonography, then we will do it TVS also, and TVS in TVS we can diagnose whether it is a generalized adenomyosis that is causing 14 to 16 week size of the uterus, or there is any localized lesion like adenomyoma or leiomyoma, or sometimes there is associated ovarian pathology also that can be ruled out. We will rule out by doing TVS. If we cannot diagnose, then we will go for other tests like sonosalpingography, MRI, or endometrial hyperplasia can be present, but I don't think it will cause the size of the uterus like 14 to 16 week size. We have to see the endometrial thickness, but in 39-year-old women, endometrial hyperplasia will not cause such big size uterus. So most likely differential diagnosis will be localized lesion like leiomyoma or adenomyoma. So thereafter we will proceed for the treatment. So her hemoglobin is like 8.6. So we will start intravenous iron therapy, and thereafter we will start treatment. Whether she is willing, we will first give medical treatment because first time she has come to us. So at first we will start medical treatment, and we will wait for at least 2-3 cycles. We will improve her hemoglobin. Then we will proceed for other treatment.
Thank you, Dr. Kavita. Moving on, we've already been mentioned the uterine pregnancy test was negative and the ultrasound revealed fibroid uterus. Here, I would like to state very specifically that when you have a ultrasound diagnosis which just says fibroid uterus, it is insufficient. The radiologist should always classify the fibroid according to its position as well as the size about the various classification of fibroids. The hemoglobin was 8.6 and she was, as Dr. Kavita mentioned, definitely iron replacement has to be done. Now, Dr. Ranita ma'am is here. Ma'am, what do you think should be the, Dr. Kavita has already mentioned the medical management should be first tried. So what are the indications for medical management and how long do you think we are going to do the medical management and what is your drug of choice?
I think before managing the fibroid uterus, we should also do an endometrial biopsy because in 22% cases there is hyperplasia or there may be malignancy also. So that we have to see, and also she is 39. If it is more than 40, definitely we have to go for endometrial biopsy. And otherwise, if there is history of family history or she is associated with diabetes, hypertension, obesity, or PCOS history is there, or there is history of non-polyposis, colorectal malignancy in family. In those cases, in a 16 weeks fibroid, we must do an endometrial biopsy before any treatment. That is very important.
Absolutely. Absolutely.
As per your question, actually, I would like to go for medical management in case of younger patients who are desirous of fertility and to also to avoid early surgical intervention. That means to delay the surgical intervention. And also in cases where we are waiting for myomectomy, then also we can do. And obviously, ma'am has already mentioned that to improve the general condition of the patient and also to improve the anemia. And in certain cases, in perimenopausal age group, when the patient is not ready for hysterectomy, and the drug of choice as of now, NSAIDs, we can go for NSAIDs followed by oral contraceptive pills, and obviously LNG-IUS for those myomas which are.
I don't think 16 weeks fibroid you can give LNG-IUS. Cavity will be distorted. Most probably, this will be a submucous.
Mifepristone or iloprostol acetate we can try for 3 to 4 cycles. But if the leiomyoma is stage 0 or 1, that depends on the
told except for 0.
In that case, we will go for hysteroscopy myomectomy. That is
easier.
We
let first Dr. Ranita go about it, and then we'll come back to the other panelists. Yeah,
Yes.
Dr. Ranita.
Yes. Actually, we'll go for the medical management like in the NSAIDs and the conventional ones, medicines, which I already spoke about. And apart from that, we can go by like for the, suppose we want to plan a surgery after 6 months, we can go for 6 months GnRH agonist. generic agonists and also antagonists. The difference between agonist and antagonist is that antagonist will have its effect immediately, while agonist will establish its hypogonadotrophic hypogonadism a little bit later. So agonist or antagonist may be tried, or even letrozole may be tried. And also what ma'am spoke about, like uripristol and mifepristol, though mifepristol is less often used, but uripristol can be used. Yes. And progesterone, in our case, maybe in cases, since I'm in a government hospital, the first mode of treatment in our case, in this perimenopausal age group, in a 16 weeks uterus, patients obviously want surgery, but we go for progesterone. First, oral progesterone. If not, actually oral progesterone for a long time to delay the periods, maybe they'll attain menopause in the meantime. If at all they are very nagging and they tell me, no, I can't buy medicines and all that, and they're non-compliant, then we often do hysterectomy, which I know which shouldn't be done, but we often comply because the patient wants to go for hysterectomy.
Thank you, Ranita. Now, Dr. Kavita was mentioning Dr. Kavita will come back. We are coming back to you. Yes, Dr. Kavita.
Yeah. So just I want to say that we will see what type of leiomyoma, whether it is like 0, 1, 2, 0, 1, 2. Can we deal with hysteroscopically? If it is causing heavy bleeding and it can be taken out hysteroscopically, we can do it, because many times with hysteroscopy this myoma can be removed and the patient gets relief of all the symptoms. So we don't think to do. But the myoma is like 4, 5, 6, and it's symptomatic and it's not getting controlled by other treatment, like all these drugs which are used for the treatment of leiomyoma, then we will opt for hysterectomy, or we can go for mammectomy depending upon the patient choice. Because many times nowadays many patients come that we don't want our uterus to be removed. So they hear from here and there, and they say that we want only tumor removal. Then we will go for mammectomy or hysterectomy depending upon the choice of the patient. But 0, 1, 2 can be dealt easily with hysteroscopy. Many times we remove myoma through hysteroscope, and it is sufficient to control her symptoms.
And thank you.
Just
yes, Dr. Sachmita.
I think it is 16 weeks myoma. If you go from the history, I think it will be submucous myoma, because there is severe dysmenorrhea and there is severe heavy menstrual bleeding. So most probably it will be a submucous myoma. And in 16 weeks, you have to hysteroscopically in multiple settings you have to do. Otherwise, chance of complications are there. And if it is more than 4, then we can go laparoscopy or laparotomy. That can be done. We can go for myomectomy in its case. Because he's only 39, we'll definitely try to preserve the uterus. Thank you.
Thank you, ma'am. So we have already gone in for the medical management, 3 months of medical management. I would just like to ask the panelists, like, what is their drug of choice?
Today itself, I had one patient. She delivered 6 months back, and now she's having a myoma of 16 weeks. We just gave her mifepristone.
Yeah,
I'm also giving mifepristone as well as giripristone, and both have good effect. I think many times a small myoma gets treated by this, but I don't think large myoma. What will be the size of the myoma after 3 months? So it depends. Or we can go for GnRH agonist also, because for 3 months we can wait. And if it is still
today's my patient, she did not have any menstrual irregularity. She had come for a mass per abdomen. So because it's not any major problem, so I just gave her and asked for after 3 months you come for follow-up, we'll see. Because he's only a small child. So I did not want to operate immediately because the symptoms are not there. That's why.
Thank you, ma'am. Does any of the panelists have a difference in opinion? So most of them have agreed that we either go in for the selective progesterone receptor modulators, that is mifepristone or ulipristal, and otherwise for the gonadotrophic releasing hormone agonist or antagonist, depending upon your choice. And most of them will be given for 3 months and followed up. And post that, if the fibroids are symptomatic like hers is, then obviously the next line of treatment is going to be so Dr. Sadhana is here. Dr. Sadhana, any other modalities of treatment do you know besides the medical management which people have been speaking about?
Thank you, Nivedita Di. there are few newer modalities of treatment in which uterine artery embolization is most widely used and most promising mode of treatment, and many centers in India are now using this mode of treatment, especially in cases of infertility with promising results. In uterine artery embolization, usually interventional radiology uses a catheter to embolize uterine artery, and uterus is not necrosed as it has lot of collateral circulation, and myoma is usually necrosed. And these cases, lot of centers in the Kolkata with promising result. And one of the center in Kolkata, when I went for the treatment of my father-in-law, they shared their experience. They are doing 5 to 6 cases per day, and the doctor asked me to refer your case if you are not doing myomectomy. And in the bigger size, 12 weeks, 14 weeks myoma, and they are giving good results. Other modes are radio frequency ablation and MRI guided focused ultrasound. These are under study and clinical trial, and we are hoping for good results in future.
Thank you, Dr. Sadhna. Yeah, sorry.
No, Nivedita, I am not going in detail because these are the newer
Okay, even I do. Yeah,
modalities.
absolutely. Dr. Santwana is here, and Dr. Santwana is doing immense work in Mission Pink Health. So, Dr. Santwana, would you just like to mention that what are the advantages of these newer modalities, especially as Dr. Sadhna just mentioned, the uterine artery embolization compared to the surgical interventions which are there, like myomectomy or hysterectomies?
Ji ma'am, though the new mode of treatments are under observation and under trial, but as it seems to be like in advantage again over the surgical treatment, they will not have any scar over the abdomen or anywhere in the body. So they are very looks very attractive, and they can be done as a single day procedure. The patient can go home after the procedure because they don't seem to like any bleeding or anything. So the hospital stay is very short. And as there is no skin cut or anything, so there are least chances of infection, and similarly any post-op complications. And because of this, because they are discharged soon and they go home very fast, so they resuming of their daily activities very soon, and it interferes. So the daily routine of the life is maintained very fast, and then they can be done if the size of a bride is very large. Then the multiple sittings can be tried with same facility of short hospital stay and discharge very fast. And repeated procedures are similarly with low risk because there is no surgical intervention. So the repeated procedures are with low risk. So these new mode of treatment look very attractive and very good for future.
Thank you, Dr. Santwana. You know, as I read these, I just feel that in another 10 years, the gynecologists will become like obsolete surgeons. Everything will be done either medically or
except baby.
Radiologically.
So baby. Cesarean के अलावा बाकी सब हम लोग छोड़ देंगे.
Only cesarean will be left with us.
Only cesarean ही करेंगे और बाकी सब चीज मशीन ही करता रहेगा.
जी जी.
And radiology is coming with a lot of
and the radiologist will have a heyday, and gynecologists will be sitting and like just doing prescriptions. So that's what. But then anyway, as they say, whatever we as doctors we have to prescribe something which is obviously causing less harm. As somebody even in malignancy says, if you cannot do it, does not mean that it should not be done. You can always refer. So yes, I agree with Dr. Sadhna. If we can refer, we should refer. So Dr. Sudha, we come back to Dr. Sudha ma'am, and they've been discussing about the surgeries. So she's 39 years old. She's already had 3 surgeries. I mean, she's had 2 cesareans and 1 incisional scar. So which would be your approach towards this case? And she's already got 2 children, living issues. And what would be your preferred surgery? Would you like to do like just remove the tumor, or would you like to counsel her and remove the uterus? Dr. Sudha ma'am.
I think she has already 2 surgeries done. Then I think we should do a laparotomy and remove the laparotomy in this case.
In expert hands, anybody which expert laparoscopic surgeon can do laparoscopically also. So I think it depends upon the confidence of the doctor and whether he or she doing laparoscopy or not. So even in spite of 2 or 3 surgeries, many times it is dealt with laparoscope, and many times myoma gets removed, especially with a morcellator. We can remove myoma even laparoscopically also. So it depends upon the what type of previous surgery there, how many adhesions there. If bowel is adherent, then it's very difficult to use any energy source. But if it's not adherent so much, and you can do slight adhesiolysis and we can remove the myoma, then it can be dealt with laparoscope also. So it depends upon the.
So because as I mentioned, she's had 2 cesarean sections and she's also had an incisional hernia repair. So with that, what is the opinion of the other people, of the other panelists? Like, would you prefer a open surgery, or would you, like, if you're doing lap, it's fine. If you're not doing, would you refer it to some other case, some other person?
In experts' hands, this laparoscopy will be better.
Yeah.
We should try out.
It's better laparoscope should be done. If it can't do, then we will refer the patient to medicine.
We should try laparoscopy first, but if it fails, then only we should do the laparotomy. Means we should have the consent from the patient's attendant earlier for this.
So this is what they were mentioning about the various types of fibroid, and definitely first the diagnosis of not just the fibroid, but about where the position of the fibroid is extremely important before you decide the type of surgery which you are going to do. And in case the hysterectomy is required, Dr. Shubhabrata, are you there? Then
yes, ma'am.
Okay, fine. Hi. What do you think? What are the indications? Which woman would you say that, okay, no, here I'm not going to do a myomectomy, here I'm going to do a hysterectomy? And in that case, which would be a preferred route of doing a hysterectomy?
Okay, the most important thing is that her family should be completed if we are planning to go for a hysterectomy. And also the patient should give consent. She should be ready to remove her uterus. Otherwise, if she is not managed, she is not responding to the medical management, we can go for hysterectomy. Again, we can go for myomectomy in that case also. Otherwise, if the fibroid is too big or too many, and there is also associated pathologies, then we can choose a hysterectomy. In the way, the preferable route will be vaginal hysterectomy. It can be LAVH also, laparoscopic assisted vaginal hysterectomy. And in case if vaginal hysterectomy is not possible, we can go for TLH or open laparotomy, abdominal hysterectomy, open laparotomy.
Yeah, depending upon the surgical skill. Absolutely.
Yes. Yes.
So just one point I would like to make, since this is a 2 previous CS. So before anybody goes in for a vaginal hysterectomy, in this case, please at least pull the cervix to see that there is no dimpling of the skin. Because that means that, okay, yes, you can pull down the cervix. Otherwise, if the uterus is adherent to the abdominal scars, then you will just have a failed vaginal hysterectomy.
Yeah, for these patients, vaginal hysterectomy will not be easy. It will be much difficult.
Please, at least at first, put the laparoscope, see what is the position of the uterus and whether it can be moved or not, then only we can proceed for vaginal hysterectomy.
Okay.
Anyway, I think most of the, we have got most of the panelists to agree on certain points, and that is, we know that medical management is here to stay. It's not that medical management is an absolute write-off. We have to have medications for decreasing the bleeding, like tranexamic acid is here now. And if you're giving tranexamic acid, then 1 gram is the dose. Besides that, you can use other medications which can decrease the bleeding, decrease the pain. LNG, intrauterine system, you have to be very particular about where the fibroid is. So that means you have to have a proper fibroid mapping here in this case. If the fibroid is obliterating the cavity, or if there is something, if you find that the fibroid cannot be, if the LNG cannot be inserted, then LNG does not become an option. However, for fibroids like fibroid 5, 6, and 7, then maybe you can insert the LNG. But be very particular about the fibroid mapping. That is something which is very important. And if, as has been mentioned by Dr. Shubhabrata, if the medical management has been done and she is not desirous of further fertility, and then hysterectomy can be done. And if she's still bleeding, if she's still having problems, then you can go in for a hysterectomy. But if she's responded, and you just have to counsel her. What I do is that I normally counsel my women and my patients that fibroid are not going to become malignant. You can live with a fibroid, and you can even die with a fibroid. So it's not going to harm you. And if we can manage to control your symptoms, then your fibroids do not really require a removal. And with that, most of them are quite comfortable with the fibroids inside their body. So any other take-home messages with my panelists would like to mention about both the cases. One is adenomyosis management and two is the fibroid management in perimenopausal age group. We will start, or anything else in abnormal uterine bleeding in this perimenopausal age group with the panelists. We'll start with Dr. Devanjana from Silchar. Dr. Devanjana, any take-home message you would like to give the audience who's sitting out here for a woman who comes with abnormal uterine bleeding in the perimenopausal age group? To do, to not to do. Devanjana was just here. Okay, we can move to Ekta.
Yes, ma'am. We should just try and convince the patient that they should have pap smear and endometrial biopsy done. They should not ignore the symptoms in perimenopausal group and if the further treatment would depend on the reports, the pathological report of the biopsy. If it comes to be endometrial hyperplasia, whether it comes to be with atypia or without atypia. If it is with atypia, we should further move to TH with BSO in perimenopausal group and postmenopausal. But if that is without atypia, we can go on for LNG IUCD insertion, and 6 monthly we should do the biopsy and confirm whether it is regressing or whether it is means continuing to be atypia. Then we will do the TH with BSO.
Thank you, Dr. Ekta. So she's mentioned one very important point, that even if a woman comes with perimenopausal bleeding PV, irregular bleeding PV, and abnormal uterine bleeding, please do not forget to do a pap smear and do not forget to do a per speculum examination. Thank you, Dr. Ekta. Now, Kavita, Dr. Kavita, what would be your point of
first, rule out pregnancy, do pap smear, SPP testing, endometrial biopsy, and then decide whether patient desirous of fertility or not. Then only we can treat. And if there is only adenomyosis along with dysmenorrhea, we can go for LNG IUS. That is, Mirena is one of the, I think, best treatment for adenomyosis. And even for leiomyoma, if it is not obscuring the cavity. If the cavity is not obscured by myoma, Mirena will be first choice. If the patient is desirous of fertility, then we can go for GnRH agonist for at least 3 cycles or 4 cycles. Then we can allow make her give the treatment for fertility. Or if the adenomyoma or fibroid is causing problem and if patient is not able to conceive, then we will move for the surgery also. So depending upon the choice of the patient, depending upon the condition of the patient, we will proceed for further treatment.
Thank you, Dr. Kavita. So she has mentioned definitely rule out pregnancy in a perimenopausal age group, because don't forget that they can also get pregnant, and always try to speak to them, counsel them, and keep them on the same page. Then we have Dr. Ranita Roy Chaudhary. Dr. Ranita? Ronita.
Yes, ma'am. Yes.
Yeah, Ronita. Your take-home message to the audience for any woman who comes with in the perimenopausal age group with abnormal uterine bleeding.
Ma'am, I was disconnected. Please repeat.
Okay, fine. We are at the fag end of our discussions. We just wanted the opinions of the expert panelists, that what would be your take-home message to the audience for any, they're sitting in the OPD, and for a woman coming in a perimenopausal age group with abnormal uterine bleeding, what would be your advice to them? Dr. Ekta has mentioned that do not forget to do pap smears. Dr. Kavita has mentioned that please rule out pregnancy. Don't think that they cannot get pregnant. Rule out pregnancies and counsel them about the need for other investigative procedures. Like you might see
Yeah, I would just like to add that the malignancy is a very scary event in a patient's life in a perimenopausal age group. So we should be very aware of the chances of malignancy. To rule out malignancy, we should be doing a good per speculum examination so that we rule out any cervical pathology as well as endometrial biopsy, which ma'am had already mentioned. Like going for a OPD basis people or some other procedure or conventional DNC, so that all the parts of endometrium are taken and we don't miss out the histopathology. So the most important thing is to go for a clinical examination by a per examination, followed by a pap smear, and also look for the ET. If she is near postmenopausal or perimenopausal, ET is very important. If ET is suggestive of that we should go for biopsy, then we will go for biopsy or people. And along with that, all other investigations that are already discussed in this panel.
Thank you, Ronita. Now we have Dr. Santwana. Dr. Santwana from Ramgarh is, as I said, a Mission Pink Health expert. Now, Santwana, your take-home message to
as
the
everything
audience.
has been told and said so nicely, I'll just like to add one thing, that colposcope is a very good tool in our hand. And with colposcope, we can just rule out any pathology in the cervix which is generally missed. Because if there is any polyps, many times I have seen with bleeding patients bleeding for 6 months or so, and there's a big polyp or a small polyp in the cervix, or it is hanging from the endometrium, and we can very easily diagnose with the colposcope, and we can remove it in the OPD itself. And it's very good in that thing. And last message, which I will like to say, that there are so many options. We should always try to save the uterus. Whether the patient desires or not, we should first go for saving the uterus first, and then we should go for other treatment, for surgical options and hysterectomy and other things.
Thank you, Santwana. I think you meant office hysteroscope. So yeah, an office hysteroscope is something which is very important. And like if you can have that facility, then fantastic. But here also I would like to add, as Dr. Ronita mentioned, that if you're doing a transvaginal sonography, and if you can add a saline sonography, then I think a lot of polyps can get diagnosed, which we think of just as endometrial hyperplasia. You can pick up a lot of polyps, and you can even find out exactly from which side the polyps are arising. So thank you. So this was another important point, that definitely one should think of an office hysteroscopy. Dr. Sadhana, hi. She's a very dear friend of mine also. Most of them, I know most of them personally. So Sadhana, are you there?
Yes, I am here, Navita.
Yeah, Sadhana is doing a fantastic job, with a lot of social activities. You keep seeing her post that she's doing a huge amount of social activities. So since you're into so much of public awareness, I think what would be your one take-home message to the public about perimenopausal abnormal uterine bleeding? Now here I want it to the public.
Thank you, Nivita Diti. In public, all the categories of women are coming, higher, lower, and middle socioeconomic group. One thing I or we all can notice कि nowadays even public is asking for कि नहीं मुझे नहीं दिखाना, आप ultrasound कर दो. But they are not cooperating with us for per-vaginal examination, and they are very ignorant कि कुछ दवा ही लिख दीजिए, अल्ट्रासाउंड, या फिर यूजुअली दे कम विथ अल्ट्रासाउंड कि मैडम ये मेरा फाइब्रॉइड है, मेरा यूट्रस बल्कि है, माय यूट्रस इज बल्कि. Whether they are educated or uneducated, they are villagers or belong to the urban areas. I am facing, whether panel is agree with me or not,
Yes,
there are
yes,
lot of patients they are treating herself with reports, and so I will request to the public ki please cooperate with us. We gynecologists cooperate with us. Many a time we have to struggle for per vaginal examination or per speculum examination. It is not such uncomfortable, but they are not cooperate. So it must be a message for public ki please cooperate to us, because lot of things can happen. Malignancy, we all know. We can diagnose only with perispeculum examination, cervical malignancy, polyp, and other pathologies in the vagina and cervix.
Thank you, Sadhana. I think that was very, very important message for the public, that please don't always rely on ultrasounds. Ultrasound is like Bhagwan nowadays. It's a panacea for everything. Sudha ma'am. Sudha ma'am, your one take-home message.
Nivedita di one thing.
Yes.
When patients comes to me and told me कि मेरे पास तो अल्ट्रासाउंड है, तो आपको नहीं समझ में आ रहा है, तो मैंने कहा कि मैं आपका फोटो खींचूंगी, तो क्या आपको पता है कि आपको आंखों से दिख रहा है कि नहीं, या कानों से सुनाई पड़ रहा है कि नहीं? ये तो एक फोटो है, ओनली फोटो. तो मुझे देखना पड़ेगा कि आपका बच्चेदानी के मुंह में कुछ है या नहीं. तो वो फिर यूजुअली कॉपरेट विद मी. ओके, थैंक यू.
Thank you.
Yes.
Even I give the same dialogue. Even I give the same dialogue कि फोटो देख के शादी नहीं करना, लड़की भी देखना चाहिए.
गुड मैम, ये बहुत अच्छा चीज आपने बताया लोगों को बात समझाने के लिए. Because उनके पास अगर अल्ट्रासाउंड है तो दे आर ऑलवेज इंसिस्टिंग कि नहीं इसी से बताइए. अभी तो कराया
Very
इसी में
reluctant.
बताइए.
Yeah.
So
They are
Sudha
very
ma'am has got
reluctant.
Sudha
Ma'am,
ma'am has got immense. Yes.
I am working as a deputy superintendent in a government hospital.
I know. That's what I was about to say. That she's got immense experience. Huh?
So, any person, any lady with this perimenopausal bleeding, we are doing mass screening to a lot of members along with the Tata Memorial support. We are doing pap smear. We are doing blood speculum examination with iodine. And this is giving immense result and saving many persons. And by speculum examination, we are seeing the polyps and doing accordingly. So my request to the people that if there is any perimenopausal bleeding, please don't stay at home. Please come. Whether they have money or they have not money, we are ready to treat them.
Thank you. Because that's what I wanted to say. She's got immense experience in the government public sector services. Dr. Shubhabroto, now from Kalyani. Dr. Shubhabroto, what is...
Yeah, I think all the point has been covered. But one thing I would like to add, because it always comes in our mind that fibroid will be a recurring disease. Once she had a fibroid, even with the management, it will recur back. So in a perimenopausal age group, we somehow our mind goes towards hysterectomy. But from these panel and from further discussion, I think the patient should also be counseled and offered the other modalities to keep the uterus so that the uterus could be preserved, because so much newer methods are coming up, and if we do not apply those, then we are also not being offering everything to our patient.
Absolutely. So preserving the uterus is very important. I keep telling my colleagues, अगर हम लोग uterus ही नहीं रखेंगे तो हम लोग क्या करेंगे? So preserving the
मुझे
uterus.
याद है हम लोग जब RMCH में थे तो उषा रानी मैडम हमेशा बोलती थी कि यूट्रस मत निकालना, यूट्रस ही निकल जाएगा तो तुम करोगे क्या फिर आगे?
So finally, I think we have with us the expert from Cuttack, Dr. Sasmita Swain ma'am, and I would like her opinion about the final input about and the take-home message before handing over to Dr. Vinita ma'am.
Okay. So regarding the classification, I just want to tell the FIGO classification, the not yet classified has been changed to not otherwise classified. And in that, important thing has been added, that is one AV malformation, malformation and isthmocele. Isthmocele has now become one major important cause of this AUB. So that also we have to look for. And in coagulation disorder, the drug-induced like anticoagulants, they have come to the iatrogenic. So that they have come.
Absolutely.
That is the modification they have done. And coming to the management part, so we have to take the patient as a holistic approach. We have to approach the patient. So proper history is very important. Then we have to do the general examination, per abdominal examination, per speculum is a must. If you do not have a speculum, at least do a PV, because many times we do not have the speculum at home. At least by PV also, from experience we can know some abnormalities there. Then we will definitely force them to do a per speculum examination. That we have to do, and all the investigations as advised by the discussed, the treatment we have already discussed. So even if she is perimenopausal, we have to exclude pregnancy, and we have to exclude malignant and pre-malignant lesions. That is very important. Above 45, any AUB, we have to go for endometrial biopsy. And if she has any high risk factor for malignancy, we have to go for, even if she is younger age, we have to go for the endometrial biopsy. Service we can exclude by the per speculum examination. For ovary, we have to do a ultrasonography, and we have to create the awareness among people that after 45 years they should come, even if there is no symptoms, they should come forward for a baseline investigation like CBC, like thyroid, like your blood sugar, pap smear, and ultrasonography. This baseline investigation should be done routinely in all elderly women. even if they are symptomless. And we should educate also them regarding the self-breast examination. That also it is our part to tell them that every month they should palpate their own breast. Any abnormality they get, they should come immediately for checkup. That we have to tell them. And another important thing, recently we have a workshop because we are discussing about perimenopausal women. We should also take the history of any girls in their family who are 9 to 14 years. So they should vaccinate with HPV vaccine so that we can prevent cancer cervix by 2030. We can eliminate cancer cervix from India and globally also. So that part also we have to play. Even if they have a daughter, maybe elderly, they can take it and their grandchildren can take it. Even if they are not belong to that age group, we can tell them 9 to 14 is the maximum effect. From 15 to 25 and 25 to 45 also we can give. Upper is now 45 according to the Fogsi. So that also we have to tell them. And regarding this AUB, we have already discussed vividly regarding every aspect of it. So we always keep in malignant is the most dreaded things. Everybody is afraid of that. So we have to always keep that in mind. That much I can tell. And like regarding that camp screening procedure, government is doing a very great job. In our state, all the ASAs, the paramedical sisters, they are being trained how to do a Costco speculum, how to do a VIA and Willi test. Everybody is, if they get any abnormality, they are instructed to send the patient to the consultant. So that only by creating awareness is our should be our domain. We have to make the people aware what are the possibilities, what disease they may suffer, because our patients, they do not know that this condition has to be treated or has to be consulted. That awareness we have to create among the people. That is our responsibility also. Thank you.
Thank you, ma'am. So,
Very true.
thank you. So I think we'll call it a day. And I would like to say that although knowledge empowers you, knowledge by you, I don't mean just the doctors, the paramedics. I also mean the general public and their family. So they should know that a perimenopausal bleeding PV is not always normal. जैसे कि this is ये मासिक बंद होने से पहले ऐसे problems होते हैं. So it's not always normal.
They think
and
it is normal.
Hence there is this terminology called abnormal uterine bleeding. So before saying that it is normal, you should always find out that it is abnormal. Exclude the abnormalities. Always remember she is not just a uterus which is bleeding. She's a woman. So correct her anemia. Give her psychological support. If she is having any other symptoms like pain, please see that is improved. Because as Dr. Sushmita just now mentioned, it has to be a holistic care. You are taking care of the woman, not just of a uterus which is bleeding. So besides the pathology which has to be tackled, you have to tackle the human being, inclusive of her financial considerations. So when you're giving the medicines, you have to also see that she can continue to take the medications. The medications are expensive. So for her to take it for 3 months, she has to be able to afford it. Hence, LNG, in my opinion, is a wonderful drug which has come up. It's cheap, it's affordable, it is accessible, it can be easily inserted by any gynecologist. And I think it gives a wonderful result even post insertion for 5 years. So I'm not promoting this is not a medium for promoting LNGs, but then definitely
no, LNG we're promoting, we're not promoting Mirina, we are LNG, I guess we are promoting. It is okay. It is the number one. According to all the guidelines, LNG I guess is the number one choice. Could be.
So counseling is very important because, as mentioned by most of the panelists, and especially Dr. Ronita was mentioning it specifically, that they're scared of malignancies. They feel that if they're bleeding, then it is going to become malignant. In fact, a lot of you see your fellow gynecologists are sacrificing uteruses just because they feel that it will become kal malignancy na ho jaye, and we will get stuck. So we should counsel them well. They should be kept on follow up, and I think finally we can really go back and have an empowered audience and empowered public with the expert panelists which have been there with us today. I really thank all my panelists. I thank the experts, and I thank the Public Awareness Committee for giving us the chance to moderate this
So our
panel.
responsibility is to aware the public regarding this. So the committee has brought us together. Yes.
But here I would like to ask, we've got it from a lot of people, but since Dr. Devanjana was not there, Helen, I can see is still there. Helen, I would like to know your opinion from your part of the like what is the major problems that you're facing with. We have discussed it from Bihar, we've got it from Jharkhand, we've got it from Odisha, we've got it from Bengal, and we would like, if Helen is there, from her aspect, because she's a malignant oncology expert, what is her opinion about abnormal uterine bleeding? One take home message. Or else Helen just kept it on and gone.
She has kept it on and she has gone.
Fine. I think we'll wrap it up. Giving it back to the Dr. Vinita. Vinita ma'am is there. Vinita ma'am? Actually, Vinita ma'am is simultaneously on another panel. She's moderating another panel. So it was wonderful of her to actually moderate 2 panels simultaneously. But in the meantime, I'll hand it back to Dr. Monica. Let me see if I can get through Dr. Vinita ma'am. Monica, I'm handing it back to you.
Thank you so much, ma'am. I'm sorry I'm keeping my video off because I'm traveling, but it was an excellent panel discussion and icing on the cake, which has promoted Save the Uterus, which is the main focus of the Public Awareness Committee since the last 2 tenures, that is since Kalyan sir's tenure.
Yes,
we are
Kalyan
carrying out the Save the Uterus activity, and we've had more than 100 webinars till now, ma'am, and the physical meetings in more than 50 to 60 cities all over India.
Yes.
So we are promoting the use of LNG as well as the Save the Uterus campaign, and we will be considering to do it in future with all the other chairpersons who come in line also. Thank you so much,
Monica,
Dr.
Helen,
yes, ma'am.
Dr. Helen is back. I think she's mentioned her mic was off. So I think we can take one take-home message from Dr. Helen.
Thank you. I really wanted to say this thing because time and time again, the emphasis on post speculum examination was put forth. And I can't put enough emphasis on this again because I have had many referrals of incidentally diagnosed cancer after hysterectomy for cancer cervix, for cancer endometrium. And the main reason I found was post speculum examination was not done. So this is one input that I want to give. And for other causes, non-malignant causes, sometimes people usually like good counseling is very important. And before convincing the patient, we should try and convince ourselves what is it that we want for the patient, what is the best mode of treatment, because then only we can convince the patient. Most of the time, I find that even I'm thinking in the line of hysterectomy because I know this patient has come from very distant, far away places, and they are yeah. So they are always thinking in those terms. In fact, there had been 2-3 cases where like they actually went ahead and did hysterectomy in other places. So post speculum examination, very important. Need to convince ourselves before we talk to the patient what are the options they have available. So I think that is very important. Thank you.
Thank you, Helen. Helen, you have brought Imphal everybody is talking about Imphal. Our department, they're ready to attend your conference. All the best for you, Fogsi.
Thank you so much, ma'am. Thank you so much.
At that time, Dr. Pai was also telling, I am going to Imphal, then I will come to Orissa.
Ma'am, you'll be missed. Ma'am, you'll be missed, okay? I wish you could have come. I'm so sorry.
I may be here, but all my good wishes are with you.
Thank you. Thank you so much, ma'am.
I'll be there, Helen.
Nivedita will be there. Nivedita, Figo video you have, or you have deleted it?
Which one, ma'am?
In Figo, that
presentation. I sent it to you. I sent it to Dr. Bhagya.
I did not get it.
I sent it to Bhagya. She forgot to send. I sent it. Usi waqt I sent it. That very moment I sent it to Bhagya.
If you have with you, please send to me.
I'll send it.
Oh, please share it in the group so everyone can enjoy, madam.
Yeah, that's what I was saying. Share it in the group.
That's very nice meeting all the people from the East Zone. It was very
Thank you, ma'am. Thank you, ma'am.
I really feel so good. Thank you.
Thank you, Monica. Thank you, Shatabdi. Whenever I see Shatabdi, I remember the Bengali movie actress, Shatabdi.
Sorry, ma'am, my network was off. Traveling. Thank you so much, everyone, for joining us. Thank you, Avarani ma'am. Thank you all our chairpersons, Rekha madam, Vandana ma'am, Supriya
Thank you,
Jaiswal madam,
Supriya,
and Helen ma'am.
also.
Thank you, Anita ma'am. And thank you, Sita ma'am, for accepting our invitation as faculty. Asmita ma'am, Nivedita ma'am, and Vinita ma'am have done an excellent job to get out the best out of the panelists, and they have given very good take-home messages. Thank you, everyone, and good night. Season's greeting, wishing you a very happy, Merry Christmas in advance, because we will be meeting in the next year now for the next webinar of the Public Awareness Committee.
Okay, thank you.
Okay, thank you.
Thank you, everybody, and good night.
Good
Thank
night,
you,
ma'am.
ma'am.